Hi everyone, very good afternoon guys. I hope I'm audible and visible to all of you. I would need a quick confirmation from everyone in the live chat box and then we can start with today's session if all is well with the AV. So welcome back, and this is the second part of the Pathology LRR that we have. I hope you found the first part useful. I hope you've got the PDF and everything that you had asked for has been settled in that part itself. I had asked you for doing 2 or 3 homeworks which I will gradually ask you as we go through today's class because that is spaced out somewhere in between as well. But a quick reminder about the Champions exam that is coming up from 23rd to 27th of April, which I think I have told you yesterday also. And this is going to be in the exact same pattern as you have your exam, which is going to be in a total of 4 sets with 50 questions, 45 minutes each. Then you have audio explanations, which is going to be an add-on this time in comparison to the previous mock exams. So yeah, that is something which I hope is going to be helpful for all of you. So I assume we can start with today's session. Rest of the instructions remain the same, guys. I think I've already taught you that this is a one for all kind of an LRR that we have. The PDF will be given. LRR will never be enough. It is RR plus LRR that you have to go ahead with for the upcoming, whether FMG, NEET or INI-CET. For INI-CET students, you had asked me for a list of extra topics that you have to do apart from this LRR, because obviously there are some extra techniques, etc. So today at the end of this PDF, I have added a slide, and maybe you don't do it right now or immediately in the next 1 week, but very close to your exam, just go through those topics from the rapid revision also. That will give you that extra edge, and you know that pre and paraclinical subjects are asked a little more in INI-CET. So they will help you definitely over there. Okay, I believe all of us are good to go, all's well, and any other questions that we have, we will take them up after the class is done. But I want with a fresh mind in the morning, afternoon, we are able to finish off whatever is planned for the day. So our plan is going to be number 1, Hemat, and second is going to be general pathology. I have clubbed questions from the previous LRR. I have added questions this time from the version X Q bank, and that's a combined LRR that I have got for you. Okay, so let's get going without wasting any time. First is like a good luck charm that I have to start with this question, because they will always ask you these needles irrespective of the exam. We have 2 techniques in hematology. Start filling the blanks, guys. It is number 1, BMA, that is bone marrow aspirate, and second one is BMB, that is bone marrow biopsy. For bone marrow aspirate, you have 2 needles. I think all of you know. One is the Salhas and one is the Klima needle. Yes, perfect. All the answers once again pouring in. So Salhas needle is known as the one with the side screw. That's how we learn it. And these are the only pictures that they have. So this is exactly what you're going to get. Because these needles, these stainless steel needles, these used to be reusable. So once upon a time they were used. Now they are not. Now we have disposable one-time use needles. So of course, these are the only images they can give you from old times. So Salhas needle will have a side screw, and then Klima's needle is going to have a longitudinal screw, as you can see over here. That's the bone marrow aspirate needle. Very good. Whereas Jamshidi's needle, that is the one that is used for bone marrow biopsy, and that is going to be a T-shaped needle that we have over here. Okay, now irrespective of the technique, the site from which it is done most commonly is going to be posterior superior iliac spine. Very good. And now if it is asked in case of maybe someone has a great amount of fat or some kind of physical deformity, you cannot do it from PSIS, then in that situation you will be going ahead with the ASIS. Then of course, coming to the third thing, that if it is a child, you can also do it from the tibia, and usually it is done from the anteromedial aspect of the tibia. So I think we are settled. These one-liners you have filled in very well. Isme no kind of clinical question can come. If a question comes, it's a straightforward one-liner, fill in the blank kind of question, all of which you have settled over here. Moving on to what I always start with. I mean, these are the first 2 slides which you will find in every LRR. But that doesn't mean every LRR would be the same. But these are 2 slides which I start off with as a basic concept. That is a question which they would always ask you with regard to this cell. They are talking about a 43-year-old female, reduced energy and fatigue. I've started thinking of anemias. That is a microcytic hypochromic anemia, and there is a past history of a chronic disease that is going on. She is on medication. Peripheral smear shows numerous enlarged red blood cells taking a positive stain with supravital stain. Now, supravital stain is a take-home message for all of you. will always indicate when asked for red blood cells. Perfect, guys. Reticulocytes. That's not what I asked. Reticulocytes are made up of what? They are made up of ribosomal RNA. So before I go ahead, do you know why we called it reticulocyte? Because cyte refers to cell. What kind of a cell is it? It's a precursor of a red blood cell. But reticulo means perfect. It is a reticulum of RNA. And now how is it stained? Because ma'am, if you want to stain RNA, RNA has one principle in life, that it will not stain like everything else. It will not give a pink blue color. It says I will only give a color if you stain me via supravital staining. Supravital, vital means living, vitality. So RNA says if you keep me in the living state, I will show you the color, and if you kill me, I will not show you the color. Which means that please do not add anything that will upset the RNA. Do not add methanol, do not add ethanol or any other alcohol. Nothing added, only one color is added, and that color is a bluish color. The best stain that we have is going to be new methylene blue, and the next best stain that we have is brilliant crescent blue. That is why whatever I'm getting in between, this is the RNA which is all bluish in color. They will not give you the normal count. You will tell me the normal count. It is 0.5 to 2%. It can go up to 2.5%. Itna na, now in hematology, this 0.5 plus minus variation goes book to book, lab to lab. So be open to that. Okay. Now coming back, now if they give you only numerical of pathology, and that is how do you calculate the CRC, that is corrected retic count. Firstly, this is calculated if you are dealing with a patient of severe anemia, usually when the hemoglobin is less than 7. That is severe anemia. And corrected retic count is given as reticulocyte count multiplied by hemoglobin of the patient divided by hemoglobin of a normal person. Very good. And because ma'am we are medicos and our math is usually not very good, so we take the normal retic count to be 15 for whether male, female, child, adult. Let's take a general retic count. And this is their favorite kind of a numerical. They also give you simple math over here. This is not like the PSM numericals. So if they say that the hemoglobin of the patient is going to be 5 and the retic count of this patient has come out to be a 6%, now you know that the corrected retic count is clearly going to be a 2% over here. This is the only math that you have to do in pathology, and you can easily do it if you know retic into hemoglobin upon hemoglobin, that is corrected retic count. Very good. Someone asked me, ma'am, is toluidine blue also a supravital stain? I'm not answering that right now because I have a question on supravital stains after 1 hour, and then I will come to that. So this is not the right time. So coming back, now if I ask you a twisted question out of this, I've given you the same reticulocyte and I have asked you what will not be included in the staining protocol of this. Will you add new methylene blue? I mean, yes, I can. Can you add brilliant crescent blue? I can add any blue color stain. Will you add equal quantities of blood and supravital stain? Yes. Will you do methanol fixation? That was the only rule that RNA had, that don't add alcohol on me, else I will not be visible. So you do not do methanol fixation, and that's the answer. See, this is specially for INI-CET students because they ask you all of these procedural and lab related questions more in the exam. Let's move forward and go on to a question without which no hematology session can be complete. Starting off with a 32-year-old female who comes to you with a routine physical examination. Her CBC shows a hemoglobin of 9. Of course, she has anemia. An MCV of 72. I don't want you to answer this question right now. I want you to tell me what kind of an anemia does she have, for which you will have to tell me all the normal values first, and all of you believe it is iron deficiency anemia. Maybe think over it once again, maybe you want to reconsider, and I will come back to this. Now when I talk about MCV, what does MCV tell you? It tells you the size of a red blood cell. MCH tells you the hemoglobin in a red blood cell, and MCHC tells you the hemoglobin concentration in a red blood cell. Now moving forward, that MCV, tell me the normal values. MCV is 80 to 100 femtoliters, which means that if MCV is less than 80, then this means the size is less. Oh, look at over here. The size is less. What kind of an anemia is this? This makes it a microcytic anemia. And we all know, and we will study a mnemonic called Sickle for microcytic anemia, which tells me that thalassemia comes under it, iron deficiency anemia comes under it. Megaloblastic is other way around, macrocytic anemia. Over here the MCV will be above 100 and autoimmune hemolytic anemia as a hemolytic anemia. So my confusion is only between two options. Let me go forward. When I talk about MCH and MCHC, amazing, you guys remember the normal values means you've studied. You start from 27 and you end at 37 is how we learnt it. So and you put a break in between. So 27 to 32 picogram is the MCH, and from 32 you start from 33. So 33 to 37 gram per deciliter is going to be MCHC. That's how you learn it. Finally, coming to RDW. RDW tells you the variation in size. Be very careful what has the examiner asked you. If he asks you which parameter tells you the size of the RBC, that is MCV, means every RBC. I'm telling you, okay, 80, 90, 100, every RBC. But if I tell you I don't have so much of time, tell me variation. They range from 80 to 110. I've told you an entire variation, that is RDW. And RDW is normally 11.5 to 14.5%. Now I want to ask you, in this question, RDW was somewhere in the normal range, which tells me that if RDW is normal versus increased, what do I think of? In increased, you will think of iron deficiency anemia, which is not the case over here. Why? Because iron, some days you will have less iron in your diet and supplements, so RBCs will be chota. Some days RBCs will be normal because iron is normal in the diet. So ma'am, iron varies with diet, iron varies with supplements, so many things. So the size of the RBCs will vary, RDW will be increased. On the other hand, thalassemia is going to be a genetic disorder, which means born with it, dying with it. That genetics remains the same all throughout the life. So RDW will not show any variation. The same chota RBCs will be there throughout life. So RDW being normal, I think more of thalassemia. But this was a very different way. What you had to put in this question was the famous Menzer's index, and despite that, you have got, many of you have got it, iron deficiency. I hope you were not thinking ma'am is starting the session, she will start with iron, then Megal, then Thal. No, we are not going in any order as such. We are not doing the main course over here. So now coming back, Menzer index, how is it calculated? It is going to be M upon R, that is MCV divided by RBC. Now look over here, MCV is 72 and RBC is 6.4. I mean, my math is pretty bad. I don't know about you. So all that I can gather is whether it is going to be above 100 or whether it is going to be below 100, and I can see over here it is going to be less than 100. It is going to be less than 100. Okay, someone says, ma'am, thalassemia at this age. Hey, we are talking about which thalassemia? Beta thalassemia trait. Trait people are asymptomatic throughout life. I am not talking about a person who's thalassemia major. A thalassemia major person, I will never have this kind of a confusion. That person will be symptomatic since the age of 6 months or 1 year or 2 years of life. I will know he or she is going for blood transfusion every 15-20 days. There will be that chipmunk faces. There is no doubt. The problem comes with thalassemia trait people because they are traits, means they are asymptomatic. They cannot 32, they can survive a full lifespan of 72, 82 and beyond also without any symptoms. So over here, if I see it is less than 13, even if my math is bad, this much I could gather, this is a case of thalassemia, and that is how we used to learn it, that thalassemia is less than 13. That is what you know, that is what is Menzer index. But this is a very crude way of doing it. If I have to do confirmation, because you are labeling someone to have a genetic problem, you have to be dead sure about it. You will have to do HbA2 levels. HbA2 levels more than 3.5% will tell you that it is definitely 100%, no doubt now, it is a case of thalassemia trait. Is that okay with everyone? Yes. Now let's not, Dr. Debaki is asking in my Menzer index less than 13, this is what you're saying, and RDW increase, can it be iron deficiency? See, we do encounter these kind of situations. That is why I'm not calling any of these as a confirmatory technique. Confirmatory will always be HbA2 level testing. So if you get stuck in any situation, you know you have to go for HbA2 either ways. Now coming back, this was a case of thalassemia, guys. For everyone who marked iron deficiency, watch out, don't be in any bias. Now let's move on to the next question that we have over here. There's a 5-year-old child who's brought to the outpatient department by his mother with a complaint of inactivity and difficulty in weight gain. On history taking, it was found that there is a relative with some blood illness, something genetic is happening in this family. On physical examination, underweight, pallor is there on skin, arms, conjunctiva, HB electrophoresis, HbA2 found to be positive basically means HbA2 levels are more than 3.5%. This is a case of what? Now you know. See, they've not given you Menzer, they've given you the final diagnosis. This is a case of beta thalassemia trait. So what is this? This is a 5-year-old child who is having beta thalassemia trait. But ma'am, you said trait patients are asymptomatic. So chota mota he has illness, but throughout life he's going to have this pallor kind of illness only. He's going to have weakness and pallor and difficulty in weight gain kind of illness. He's not going to suffer from anything major beyond it. But now I want to ask you that what if this child at the age of 30 gets married to another person who has the same beta thalassemia trait? I'm making you solve two numericals over here, and you will do this 2 by 2 school jaise hum karte the. So if this child gets married to another girl who is having beta thalassemia trait, so tell me, the first kid that is born to them will be totally normal, the second kid born to them will also be beta thalassemia trait, the third kid born to them will be beta thalassemia trait, but there is a chance that a fourth kid born to them can be thal major. Question asked is that if a thal trait ends up marrying a thal trait, what percentage of kids will have thal major? 1 out of 4. Very good. How many percentage? 25%. Patho ka maths is very simple, basic math they ask you. किसी से भी हो जाएगा. Perfect. Now I changed the situation. This was only when thal trait marries another thal trait. Usually what we see in the general population is that a thal trait gets married to a normal person. Then is there any chance of any kid having thal major? Then of course, if only a single small a is there, there is no other small a, then there is no chance of having thal major in any kid. Then the chance is going to be a 0%. You need to know this for your general knowledge in genetic counseling also. People, two couple coming to you with thal trait, both having thal trait, 25% chance to the kid for major. One having thal trait, one completely normal, 0% chance for the child having thal major. Okay, this is settled. Now we move on to the next question, which is important more for for FMG students, because they love to ask you this same photo again and again. That is the Nestroft testing done for thalassemia. The full form of Nestroft test is in front of you. It is a naked eye, which means you don't have any microscope over here. It is a single tube, because I can see a test tube over here, and you are testing for red cell osmotic fragility. Whenever I have to test for fragility, breaking, weakness, fragile, I will take the blood and I will mix it with saline, normal saline of course, and after that I'm seeing is the blood breaking or not. Please note that the normal cells, the normal RBCs, like in your RBCs, my RBCs, we will break. Our red blood cells will break. But do you know thalassemia red blood cells? Thalassemia red blood cells are very tough. They cannot break. In the exam, what do you guys have to be? No matter what, we don't have to break. What do you become till the exam? In pathology, I make you thalassemia cells, and in microbiology, I make you one parasite that is H. nana. And if you know, then you know. And I will teach you later on. In parasitology micro, I will make you H. nana, but in pathology, I tell you to be thal cells. In life, you have to be thalassemia cells and very tough. No matter what pressure comes on you, you ain't breaking. So please remember, the RBCs will keep standing no matter what normal saline I put, which means that if the RBCs are constantly standing and they are not breaking, will you ever be able to see the background black color line or any paper behind it? No. This means this is a case of thalassemia. On the other hand, if these were my RBCs, normal person, but normal RBCs ended up breaking, as a result of which I can easily see the line present, and that would indicate a normal person. Sickling and Nestroft is not the same. I will come to that in a while, doctor. So now coming back, if I say, if I have to write thalassemia, I will now put it up as number 1, ma'am, screening test examiner asks me, thalassemia means Menzer index less than 13, and thalassemia means will you be able to see the lines? There are going to be absent lines that we have. I don't see any lines over here. I don't see any lines over here. Is that okay with everyone? It's the opposite in hereditary spherocytosis, जो हम कुछ देर में पढ़ेंगे. We will study that. Right now we have started with Nestroft, but please note this is a very crude method. In today's date, no one does all of this. This is only for MCQ purposes, because this is a very, very layman kind of a method of testing for a genetic disease like thalassemia, but some things you do for the exam. We are doing hypotonic saline, Dr. Monica. Okay, moving on to the next question over here. Based on the iron profile, what is the most likely diagnosis? Serum iron is less, ferritin is less, Transferrin saturation is also less, but TIBC is increased. The only increased parameter is TIBC. Rest everything is going to be less, and that is your favorite. That is your favorite, iron deficiency. Guys, everyone wants pura topic cover kar lo, but give me time. We have Hemat for almost 1.5 hours today. I will come to the genetics, but please give me time. Okay, coming to iron deficiency, which means that now you have to solve this entire table. So my suggestion to you is let entire Hemat get over. After that, if you feel something is missing, then let me know. Okay. Now coming back, when I talk about microcytic hypochromic anemia, like over here you said iron deficiency hai. So now these are all the options. You will fill in the entire table. You will also tell me the clinical scenarios. So for example, sabse pehle you learn it as Sheetal. What is microcytic? Ma'am, microcytic means when the MCV is less than 80, because you told me normal is 82, normal is 80 to 100, right? Okay, so MCV is less than 80. Now I come down to what is Sheetal, that is sideroblastic anemia, iron deficiency anemia, thalassemia, anemia of chronic disease, and some people say lead poisoning. I think lead poisoning goes into sideroblastic. So now I want to ask you, what clinical history will they give you for iron deficiency anemia? Ma'am, some dietary related thing, okay, some blood loss, ye to hum bana lenge, but tell me one parasite that will be given for iron deficiency anemia. It is hookworm. Secondly, any dermatology finding of nails that will be given, that is koilonychia or spoon shaped nails. These two things that are mentioned are very, very characteristic of iron deficiency. Now in iron deficiency, I will notice its deficiency. So serum iron will be less. Iron transfer, transportation of iron is by transferrin. If there is no iron, then the transferrin saturation will also be less. And what is ferritin? That is the storage form of iron. If there is no iron, then the storage form is also going to be less. And that means that total iron binding capacity, the hunger, the capacity to bind iron is going to be a lot, which means you are in a complete poverty situation. You have no iron, no transportation iron, no storage iron. So that means your hunger to attach iron and capacity will be very, very high. That is the scenario you get for iron deficiency anemia. Versus the complete opposite. This is deficiency, sideroblastic is iron excess. Now, why does iron excess happen? Iron is normal only in other ways, but we are not using iron. See, iron had to be used for hemoglobin formation. Now, iron is ready the way it is always, but iron has to bind with something that you have studied in biochemistry to make hemoglobin. Iron binds with protoporphyrin. Imagine if iron is all ready to make hemoglobin, but protoporphyrin is not ready, then also anemia will occur. So, sideroblastic anemia is a situation in which you feel iron is more, and you will wonder, iron is more and still anemia is occurring? Yes, because protoporphyrin is not coming. So, the reason for sideroblastic anemia is that protoporphyrin metabolism has gone for a toss. Now, why all can that happen? Very good, ma'am, that ALA enzyme levels are not there. I've given you all the histories that you can get for sideroblastic. Number one, for protoporphyrin, we need the ALA synthase, ALA dehydratase. Those ALA enzymes are not there. Do you know in biochemistry, these ALA enzymes require a vitamin for their cofactor? Very good, vitamin B6. So if there is a vitamin B6 deficiency, then also this pathway will not occur. Tell me one anti-tubercular drug which can be associated with this deficiency. It is isoniazid, so they can give you that history also. Further, this pathway will not occur if there are two poisonings. One is if there is excessive alcohol consumption. Second, if lead poisoning. That is why I told you lead poisoning is ultimately a type of sideroblastic anemia. Whatever may be the situation over here, ma'am, now the story is that iron is in a lot of excess, but this poor protoporphyrin has not come. That is why hemoglobin is not formed and patient has anemia. So iron is in excess. If iron is in excess, it will travel more, transferrin saturation will be more, it will go and sit in the bank account also more, that is more in ferritin, and then obviously the hunger is going to be less. The TIBC becomes low. So can I say IDA and sideroblastic are complete opposites? This is full poverty situation, this is full Ambani situation. Too much, excess, abundance is there. Now we come to the third one, that is anemia of chronic disease. Their favorite chronic disease that they give is going to be rheumatoid arthritis. That's their favorite most chronic disease. And if I ask you the pathogenesis first in anemia of chronic disease, number one, there is always some chronic disease like rheumatoid arthritis, usual favorite. Whenever rheumatoid arthritis happens or any chronic disease happens, there is an increase in an interleukin, they ask you, and I'm going to make you a table for where all interleukin 6 comes. There is something called interleukin 6 which increases. This interleukin 6 goes and acts on the liver, and then the liver is going to release, excellent guys, hepcidin. They ask you which is the molecule responsible for AOCD. It is hepcidin. People call it hepcidin, we call it hijacker. It is going to hijack the system. See, you are eating iron, vegetables, supplements. You think iron is getting absorbed, but hepcidin is not letting your iron get absorbed. No iron absorption. You fill in the blanks. If hepcidin is not letting iron get absorbed, from which part of the intestine? I hope I've not written that, and I hope this is very obvious that the iron is going to get absorbed from the duodenum. I mean, such baby questions I'm not going into. So iron will now not get absorbed from the duodenum, which means the iron levels will go down. If iron levels will go down, then the transferrin saturation is also going to go down. I mean, that is also obvious. But then you take the help from your ferritin, from your stores. But hijacker will not let you use your bank account also. Hepcidin doesn't let you use your stores, which means there is so much of money in your bank account and us pe interest lag raha hai, like FD. It is getting on accumulated, and that is why we are having an increase in ferritin, which means that ferritin is increasing. And imagine, I have iron in my food, but I can't absorb it. I have iron in my bank account, but I can't use it. So water all around and not a drop to drink. That is how I learn it, which means there is iron in the food, but I can't absorb it. There is iron in my bank account, but I can't use it. So now tell me, if your body knows that, yeah, there is iron in the bank account, at the back of the mind, your body knows, so the hunger is obviously going to be less. The TIBC is going to decrease. If you had to fill in the blanks over here, in anemia of chronic disease, initially it tries to show you that, oh, I have no iron and I have no transferrin saturation, but the bank account is stuffed with iron, ferritin, because it is not being used, because of which the TIBC is going to be decreased. One more thing, guys. Now, I've always told you, you have to do a raid of the bank account. In the exam, if you feel iron is low, transferrin saturation is low, raid the bank account. If you feel bank account is genuinely low in balance, it is poor, truly poor. But if the bank account is filled with money, yes, all of you are writing pseudo beggar, which means the beggars of Delhi and on I think every city has beggars on the red lights who are showing to you that they are very, very poor, but probably because they are living on tax-free money, they are richer than all of us. So their bank account has so much, or their savings has so much of money, and that is why their hunger is less. There was another way of learning it, right? Another way of learning it was, it is TIBC is top in iron deficiency anemia, and it is going to be bottom in chronic disease. I hope if the bank account story doesn't reach you in the exam, the TIBC, it is top in iron deficiency anemia and it is bottom in chronic disease. Now, one more thing, anemia of chronic disease is microcytic hypochromic, but can it be more than that normocytic normochromic? Yes, because I'm seeing a lot of variation in iron. So if you have an answer of both, mark both. But if you have to select one, anemia of chronic disease, ye pucha gaya hai, normocytic normochromic is more common, that you have to know in the exam. So if I now go forward and ask you one last thing, ki, acha, what was anemia of chronic disease because of? It is because of interleukin 6. Where else? How can you forget the era of COVID? Remember that cytokine storm story? People were having excessive interleukin 6, because of which they were having symptoms of COVID. So you cannot forget over there. And later on, I will teach you that there is one tumor. What is this? Multiple myeloma. Multiple myeloma is the cancer of the plasma cells. When they will ask you, why are plasma cells increasing? Which interleukin causes multiple myeloma? That is also interleukin 6. So these are some interleukin 6 questions that, yeah, you started telling me the drugs also. Perfect. Who can forget COVID times, right? Okay, now coming to the next question. See, you have reached such advanced phases of life. An examiner is like, look at the hand and tell anemia, look at the nails and tell anemia. So if you had a nails story of koilonychia, you were saying iron deficiency anemia. You studied so many tests, examiner is saying nails dekh ke batao. Now you've studied so many tests, examiner is saying, look at this photo, classical photo of hyperpigmentation of the knuckles. Yes, hyperpigmentation of the knuckles. I will always think of B12 deficiency. Further in this patient, yes, there was weakness and fatigue, but there is a pure vegetarian diet, no eggs, no meat. Again, the B12 deficiency is very common in pure vegetarian. In fact, if someone is vegan, then it is all the more severe. Vegan people don't even have dairy products. Vegan people don't even have milk and milk products, so their B12 deficiency is even more severe. So B12 deficiency is kind of certain over here, and this photo is their favorite. There is going to be a hyperpigmentation of the knuckles. They have been asking, see, you've reached such advanced phases. They are saying, haath dekh ke anemia batao. This is B12 deficiency. They will say that which of the following features are going to be seen. That is hypersegmented, yes. But before I go into this, when would you say low serum ferritin? Low ferritin would have thought of me, got the thought of iron deficiency anemia. Normal thrombocytes and leukocytes, so is a very vague statement, normal sab kuch. And where do you see Heinz bodies? It is, I will tell you in a while, it is seen in G6PD deficiency anemia. Over here only hypersegmented neutrophils were coming up. So that means for B12 deficiency, these are the classical photos that I can get. Full B12 deficiency story in one place. Number one, there is going to be hyperpigmentation of the knuckles. Secondly, you see these very characteristic bodies that is known as Howell-Jolly bodies. Howell-Jolly body pe 3 questions. Are they single or are they multiple? I can see only one dot inside every RBC. So they are definitely single. I've always taught you be happy and jolly to be single. I mean, no one is happy and jolly to be single, but till the exam at least, for your focus and concentration, be happy and jolly in being single, and after the exam you can mingle as much as you want to. So happy jolly to be single is question number 1. Second, what is it made up of? It is made up of DNA remnants. So we know that does an RBC have a nucleus? It doesn't have a nucleus, but now there are some nuclear remnants that are staying back, and that is a Howell-Jolly body. So where is it seen? It is seen in Megaloblastic anemia that you are studying right now, but isse zyada inka favorite question hai. Howell-Jolly bodies are going to be seen in cases of post-splenectomy. Post-splenectomy, there are 2 favorite questions that, I mean, those are the only 2 questions they ask you. Number 1 is going to be Howell-Jolly bodies, and second, forget post-splenectomy, but pre-splenectomy, do they want to give some vaccination? Yes, ma'am. Prophylactic vaccination pre-splenectomy is given, and that is usually of which organisms? The organisms which have a capsule, because you know normally spleen protects us from capsulated infections. In these patients, there is a chance that you are removing the spleen, so they will start having capsulated infections. You will give them a vaccination beforehand. Give me some random examples. I will teach you day after tomorrow in microbiology also. Neisseria meningitidis, because that has a capsule. Haemophilus influenza, because that is going to have a capsule. Streptococcus pneumoniae, because that is going to have a capsule. Just a quick recap. If you've forgotten, never mind. All capsulated infection vaccination you have to give over here. Now coming to the next one. What is this? Who can forget the famous figure of 8 appearance? That is a cabo ring. Does it have to be necessarily 8? Because what cabo ring is an amino acid, which is arginine, that has made a mitotic spindle. You remember in school you used to study those prophase, metaphase wala mitosis. Chromosomes used to get arranged in different plates, and they used to hang on a very thin thread called mitotic spindle. See, it's a thread. If thread, for example, this is the wire that I have of this mic, and I hope I don't ruin it, but I can now twist it and turn it in any direction. I can make a round out of it, I can make an 8 out of it, whatever imagination I have. So this can be of any shape. It can be 8, it can be B, it can be 0, it can be D. So cabo ring ka shape can be anything. It is a mitotic spindle. Coming to the next, hypersegmented neutrophil. I've understood neutrophil. Normal neutrophil has how many lobes? 3 to 5 lobes. Hypersegmented will say that there is a criteria that I have to follow. Either 5% of the neutrophils are going to have 5 lobes. That is criteria number 1. If that is fulfilled, okay. 5% neutrophils, 5 lobes. Or even if one neutrophil, not 1%, even if one single neutrophil has 6 or more than 6 lobes. So if I now just zoom into this, 1, 2, 3, 4, 5, 6, 7, maybe an 8th one attached. Chalo, even if you go lower counting 7, ma'am, you said anything having 6 or more than 6 lobes, then I don't count anything else. Even if I get one neutrophil like this, it is hypersegmented neutrophils. Is that okay with everyone? Now, because you're doing so much of bodies, rings, etc., solve a question which is my favorite kind of question, because I think examiner does not give image and options now, gives a question and images as the option. That is a new pattern that could come up. Patient shows a blood reports with decreased B12 and folic acid, megaloblastic anemia. Based on the above profile, what is the peripheral smear going to show you? Don't give me answers of ABCD. Give me in B12 deficiency what is going to be seen. Of course, because D, we just now studied that is Caboring, and that is the answer, which means you will also tell me all the others. But before I move on to this and I come to these pictures, I want to ask you a question. Homework from yesterday makes a comeback. There was a 6-month-old infant who presented with failure to thrive, diarrhea, and poor weight gain. A peripheral smear showed a characteristic appearance, which I taught you that it is going to have those spikes. What is that? Yes, ma'am, those were acanthocytes. And based on this, you thought along with that, okay, triglyceride problem. Okay, I had taught you yesterday this is A beta lipoproteinemia. I told you a homework, give me the mutation tomorrow. Although all of you were really kind and you gave me the mutation yesterday only, that is MTTP gene mutation. It is something to do with triglyceride transport. Now I understand that, oh yeah, there is a problem in triglyceride transport, and along with that there are acanthocytes. Why did I teach you randomly this in B12 deficiency? Because now I want to teach you all the other, not B12, but all the other options mentioned over here. Can you notice the same acanthocytes coming up here as well? Yes. So now what we'll do, we'll take up each one of these and start off. What is this? I think no one will have a problem in identifying option A. I mean, let me mark the answer is clear for B12 deficiency Caboring. I'm dealing with the other options. What is this, ma'am? Classical sickle cell. Sickle cell की बात तो आज करनी है because of that update. I will talk about it. Sickle cell is known as drepanocyte. Okay, what is option B? Option B is known as bite cell, because I can see that bite cell happening over here. Bite cell is known as degmacyte, and it is seen in G6PD deficiency. Guys, don't get confused in the exam between drepano and degma, because they are both D's, but one is sickle, one is bite. So remember dog bite. Remember dog bite, which means that degmacyte is going to be a bite cell and drepanocyte is going to be sickle cell. Sickle cell, of course, sickle cell anemia. I have not written, common sense. Bite cell or degmacyte is going to be seen in G6PD deficiency. Now we come to this picture. Let us take this picture on a separate slide, because I can see cell number 1, cell number 2 and cell number 3. Lots of things coming up our way. Cell number 1 that I have marked over here is what? This is a target cell. You can see the photo. It's obviously looking like a target. That is also known as codocyte. Now they're asking you new questions. Target cell can be seen in many different disorders. Thalassemia is one of them. For INI-CET students, apart from thalassemia, they will write some kind of hemoglobin disorder. Could be hemoglobin C, could be hemoglobin E, and those are where thalassemia and hemoglobin disorders show you target cells. Now coming to the one that is showing you proper spikes, that is known as acanthocyte, because it shows you spikes. That is why you call it the spur cell also. And this is seen in A for A, that is A beta lipoproteinemia, and you've done the fill in the blank. It is the MTTP gene mutation. On the other hand, you can see a cell which is showing you very little. Look at, zoom in and see. Ma'am, बहुत छोटा, not spikes I would say, but very minute spikes. Very little blurry kind of membrane. Very tiny blurry membrane. These blurry spikes are going to be the blurry Burr cells, also known as echinocytes. Burr cells are going to be seen in B for Burns and U for uremia. Burr cells are seen in B for Burns, U for uremia. I also called it echinocyte. So they are seen because of EDTA changes. If you have kept your blood, see the most common vacutainer as EDTA, right? So if you have kept the blood in the vacutainer for very long, those EDTA changes could result in echinocytes also. So target cell done, acanthocyte and A beta lipoproteinemia. Echinocyte seen in EDTA changes, also known as Burr cells, seen in Burns and seen in uremia. Sare cells ho gaye. This entire image bank we have discussed. But the story is not over. जब इतना अच्छे से images you discussed, tell me 3 more images and finish off all the RBC photos. Howell Jolly bodies, so right now you told me, remember happy and jolly to be single. Ma'am, every RBC is showing me only one Howell Jolly. See, strictly only one Howell Jolly body scene. Because this is still exam. Happy and jolly to be single. What will you become after the exam? I mean, I'm not telling that you have to, but in case you wish to. After the exam, no single, ma'am. We are going to mingle. And that means we are going to become multiple bodies. These multiple bodies are known as Pappenheimer bodies. Multiple bodies are Pappenheimer bodies, which are made up of what? They are made up of iron. And iron anemia was which one? It was the sideroblastic anemia. Remember, there was too much of iron, the Ambani situation. Sideroblastic anemia can show you Pappenheimer bodies. So single and jolly, happy, jolly, single bodies. Pappenheimers are going to be the iron. And I'm not asking you, I'm actually putting a tick mark. What is the special stain for iron? Because I think I have asked you a trillion times. It is Pearls or Prussian blue stain. And you actually know this. So I am very confident on it, and hence I'm not writing it. But now I notice, why are these photos looking so nice, red, pink, like blood, na? Reddish, pinkish? Because the usual stain which is used in hematology is what? It is the Romanovsky family. Give me some examples of the Romanovsky family stain, guys. One is the Jimsa stain, one is the Leishman stain. Ma'am, all of these are Romanovsky family member stains, usual stains of hemat. Because now I will talk about a body which is totally different, and that is known as the Heinz bodies. I just now taught you that Heinz bodies is seen where? It is seen in G6PD deficiency anemia. I mean, that we know, but what are Heinz bodies? Because suddenly I would have thought, ma'am ne kaha tha happy and jolly to be single. I saw single body, I marked it as Howell jolly body. But this was not Howell jolly body, this was Heinz body, because Heinz body is nothing but a denatured hemoglobin. When I say denatured hemoglobin, hemoglobin has been spoiled. See, G6PD is deficient over here. Now, if G6PD is deficient, then we are going to have damage. Now, tell me the pathogenesis. If G6PD is deficient, who is going to be on a rise? H2O2 will be on a rise, and H2O2 will say, hang on, I'm going to spoil your hemoglobin. Now, the rule is that Romanovsky stain said, I will stain normal hemoglobin, nice, red, pink, all happy, I will stain it. But if your hemoglobin is kharab, spoiled, then I'm not gonna stain it. For spoiled hemoglobin, get your own stain. That is why here you have used crystal violet. The question is, which is the body that cannot be stained on Romanovsky, for which you require crystal violet? And do you know crystal violet also happens to be a family of supravital stains, and that is how you will be staining the denatured hemoglobin. Someone said, how to differentiate it from signet ring? Signet ring is something you see in histopathology, and no one is going to throw you in an ocean of a photo and then just not give you any history. I mean, if they give you a history of a Krukenberg tumor and biopsy picture, that is where you see signet ring cells. You don't see signet ring cells in a hematology slide, right? Now, moving forward, if I ask you a question which is similar to this, I think I have done the work for you already. I have done a lot of homework for you in this question. If they say supravital stains are used for the identification of all except, so supravital stains were for reticulocytes. Yes, new methylene blue, brilliant crescile blue. Reticulocytes are nothing but ribosomal RNA. Same thing. Then new methylene blue and other supravital stains, Heinz bodies. Ma'am, crystal violet is also a supravital stain. What is not stained? I think this was a very obvious question, hence I had only answered it. Copper is not stained with supravital stains, because copper we have always learnt as RRR. Copper, the stains are rhodanine and rubianic acid. Guys, have I written it correctly or have I made a spelling error? Should I have written rhodamine over here? Have I done a mistake? Do you want to correct me, or am I right? Ma'am, we think you're right, because rhodamine you will teach us after 2 days. Rhodamine is for Mycobacterium TB, right? Whereas rhodanine is for copper. So here you are right, and these are not supravital stains. That is what you marked. One more supravital stain that you can add over here is going to be toluidine blue. Toluidine blue का क्या काम होता है? Toluidine blue is the special stain for mast cells or basophils. I will teach you that in 10 minutes. Mast cells or basophils are going to be toluidine blue positive. Okay, so now toluidine blue is also a supravital stain. Then reticulocyte wala new methylene blue is also supravital. Then this Heinz body wala crystal violet is also supravital. I hope there is no confusion on supravital. Now coming back for INI-CET students, one photo I want to add more. So bodies are clear with everyone. When you go in the exam, you will first see stain kaun sa hai. Romanovsky wala nice red wala stain hai. If they are single, happy jolly single. If they are many, then that is Pappenheimer bodies. If it is a weird grayish color ka dull sa stain, that is crystal violet, means they are trying to show me Heinz body of G6PD deficiency anemia. Is that okay with everyone? Khushi, I have already told the difference. Supravital staining, we don't do methanol fixation. I taught you this right in the beginning. The first slide I taught you, supravital means you don't add alcohol in it. Now moving forward for INI-CET students, they will give you this kind of a picture and they will say that this is from a bone marrow, like a bone marrow aspirate they mention. And in this bone marrow aspirate, they are saying that these are RBC precursors. But ma'am, RBC precursors are showing me as if dogs have those ears, na? So these are dog ear projections. Which infection will show you dog ear projections? Very good. Parvovirus B19, thoda micro coming your way. Now please note, day after tomorrow, I'm making my life a little easier ke dobara na padhana pade. Parvovirus has it in its name. If they ask you, what does Parvovirus B19 attack? It attacks the P antigen of the red blood cell precursors. Okay, now it makes sense. It goes to the bone marrow and it attacks the RBC precursors. Which antigen? P antigen of the red blood cell precursors. That is why the red blood cell precursors show you dog ear inclusions. And now tell me that if red blood cell precursors are being attacked, they will ultimately stop working. They'll say, okay, fine, we are died. Will this result in pure red cell aplasia? Pure red cell aplasia, or if the entire bone marrow stops working, it will result in aplastic crisis. That's the question that you get in patho. Which is the virus responsible for aplastic crisis? That is parvovirus, because I know it is attacking the red blood cells. I will talk a lot about this in micro, but this is the patho segment of it that I have already covered. And this was for INI-CET students. Now coming to a question which I've got from the Q Bank, which I have also marked, which of course was correct till a few weeks ago. But now the options and the answers both have changed. What you know as of now about sickle cell anemia is that at the beta 6 position, they used to say there is one amino acid changing into another, and we used to focus only on the amino acid. That glutamate is going to go away and it is going to be replaced by valine. So valine is going to be welcome. Glutamate goes and valine is welcome. But the story that has changed, because their way of numbering, naming a gene, naming the DNA, numbering the DNA has changed. Hence now instead of beta 6, it is beta 7. This is an update in the books, guys. So you please have to be very, very careful. I mean, it's not even there in the books right now. It will eventually come in the books in the next 6 to 8 months. But for your exam point of view, it is settled. So like over here, 7th option was not there only, ma'am. 5th and 6th was there. Then I go by the pichla wala answer. But if at any point in the exam you have beta 7 position mentioned, this will be the latest answer. So I'm talking about sickle cell anemia. Let's talk about a clinical history, exact copy paste PYQ from NEET and FMG exam. There's a 10-year-old Afro-American boy presents to the emergency department. I can see hepatosplenomegaly as one finding, and the skull x-ray, I'm sure everyone is very, very certain on this. This is the crew cut appearance. Now, as soon as they say crew cut appearance, I think of two things. One, crew cut appearance is known as hair on end appearance, and it is seen in two conditions. One is sickle cell anemia, one could be thalassemia, right? Crew cut is sickle cell and thalassemia. But now when I saw the photo, I can see sickle cell. So I'm not confused whether sickle cell or thalassemia. Here they're talking about sickle cell. Lab investigations show reduced hemoglobin because it is anemia. Elevated LDH. Whenever the blood breaks, enzymes come out of the blood. This means they're trying to tell me about blood breakage, hemolytic anemia. Red blood cells are shown in the picture below. Sickle cell anemia. What is the most appropriate initial treatment? Now I look at all the options. Most of you have given an answer of A, and this no one thought that maybe this could be a multiple option correct, which I am telling you now. Do you want to read the rest of the options and tell me that maybe more than one? Because I buy your answer of hydroxyurea, but you also need to understand that there is an initial treatment asked, and your patient over here has come to you with reduced hemoglobin. I think I would also want to go in for a blood transfusion to temporarily correct the hemoglobin that this patient is suffering from, low hemoglobin. So in that situation, A and B would be the best answers to give up over here, right? Symptomatically, I mean, if the patient has anemia, you want to correct the blood counts also. And of course, after that, you want to do treatment of sickle cell, which is going to be hydroxyurea. Is this like the permanent cure? No, this is a treatment which I'm doing only to prevent the patient from sickling. This is a genetic disorder. Permanent cure looks rather difficult, but this is going to help in symptomatic relief to the patient. So these are all the questions that I've got for you. Number one, for crew cut appearance, you will think of sickle cell anemia and thalassemia. Next, sickle cells are known as what? Are they degmacytes or drepanocytes? Sickle cells are drepanocytes because degmacyte was dog bite, that was bite cell. And now the question at beta 7 position, glutamate, will change to Valine. Many of you are saying that, ma'am, but now we also have monoclonal antibody therapies for sickle cell, and I'm not denying that. But look at the question again. I could have come down to all of the above also the answer. Is that the first line of treatment? Is that, and forget first line, is that the initial treatment as soon as this 10-year-old boy would come to you? Not the initial treatment. See, the same question came for a reason, because they were trying to mess you up in a lot of ways. They are asking you for the initial treatment. New therapy is there, monoclonal antibodies are there, and I'm not denying that. But initially, your first goal is to stabilize a patient whenever he or she comes. This person has come with reduced hemoglobin, hepatosplenomegaly, crew cut appearance, LDH is increased, stabilize, and then after this, if this is removed and multiple options are asked as what are the different treatment options available, then I agree with you. But over here, when this came, the word initial was there, and initially, obviously, I will go for blood transfusion and hydroxyurea. Is this okay? Single best was not asked in this exam. If it would have been asked, then both of these wouldn't have been in the option, because this is what you're going to do both. You can't pick one over the other. And in case they give you this and they say single best select karo, they will give you something else. Like if they say the patient's hemoglobin is currently very, very low, say a 3 gram. So my first option will be to give a blood transfusion and at least increase the hemoglobin. 2 units I can give, 2 gram hemoglobin can be increased, and then I will think of hydroxyurea or monoclonal antibodies. So if something like single best arises, they will give you more information, and then you will be able to select the single best answer. Yes, Dr. Vishal, I'm mentioning it again. The question and the options have changed. There is an update. It is beta 7. Now I go on to the next question. Sickle cell story is not over, so hang on. Right now, what did you see? You saw a peripheral smear and you could see the sickle cells. That is why you were like, a simple question, ma'am, this is sickle cell anemia. What if you wouldn't have seen the sickle cells? Would you have been very certain it is a normal person? No, please note, sickle cells only tell you sickle cell anemia. But if sickle cells are not seen, there is a chance that the sickle cells are hiding. It is a case of sickle cell trait and they are hiding. They are not visible. They are visible like this, but you can't see sickle cells. You think are a normal RBCs, but patient has trait. Trait would mean what? See, sickle cell anemia means HBSS. All hemoglobin is sickled. Sickle cell trait means HBAS. Because of this adult hemoglobin, the sickle cells are hiding now. What is hiding? I will take it out. Yes. What is the next thing that you do? I will go in for Sickling test. Very good, guys. What do I do? How should I remove? How should I make them show their real colors? They are currently like this. They are not showing their true colors. For them to show the true colors, I will add a chemical called 2% sodium metabisulfite. Acha. Now for INI-CET students, any sodium kind of chemical written, sodium metabisulfite to sabhi ko pata hai. If they say dithionite, it means these are just like sisters and brothers, chemistry lab, some different salt, but working is the same. Sodium metabisulfite, sodium dithionite, whatever may be used, it is doing the same thing. And what does it do? It's an agent which is going to decrease the oxygen. It causes hypoxia. So all the cells which were looking all nice and innocent, now they will start showing you their true colors and they will change into the sickled format. This is known as the Sickling test. So no one will ask you Sickling test is done for sickle cell. They will ask you what is the chemical used over here, 2% sodium metabisulfite. After this is a screening test, not gold standard. For confirmation, you are going to do these two. One is HB electrophoresis and one is the gold standard, which I will come to. First, let me show you what is HB electrophoresis. I will zoom into it. In the exam, when you go, you have to figure out where is the anode and where is the cathode, and examiner will write it for you. Anode and cathode ढूंढने के बाद, you are going to write HFSA. What is HFSA? That when we go for different hemoglobins, near the anode, we will start with hemoglobin adult. Next coming is hemoglobin fetal. Next coming is hemoglobin sickled. Next coming is hemoglobin A2, and then of course we have cathode. So what did you learn it as? You learned it as HFSA. Very, very good. We start with hemoglobin near the anode is adult, fetal, sickle and A2. And on the basis of this, let me just ask you any random, let's say I ask you this patient, can you, and just look at these two. You don't look at the light wala lines. This is your cathode end. No. You only look at the dark wala lines. Can you tell me the diagnosis of this patient which I have encircled? For this patient, ma'am, we noticed, yes guys, come on, I can see a little bit of, okay, sickle wala hemoglobin, I can see a little bit of adult wala hemoglobin. So this is a combination. This must be a sickle cell trait. A is also there, S is also there. Can you tell me the diagnosis of this patient? This patient is only S. Only S means this is a case of sickle cell anemia. That is how we are going to do the diagnosis for these patients. Is that okay with everyone? Yes? Okay, I want to ask you one more question. What is this? I can see fetal hemoglobin. I thought bachcha hai. But then bachche mein I saw adult hemoglobin also. So one possibility is maybe he's in that 6 month, 7 month age group, whereas fetal hemoglobin is going away and adult hemoglobin is coming. So this could be a normal stage also. But what else could it be? Adult hemoglobin and lot of fetal hemoglobin. Yes, this could be a case of thal major. In thal major patients, you can get fetal hemoglobin. So just one small little thing over here. If you get only sickled hemoglobin, it is sickle cell anemia. Matlab last day na you read this table and go and you are settled. If you see HbAs, that is sickle cell trait, yahan tak we know ma'am. If you see HbA2 levels coming more than 3.5%, you know that is beta thalassemia trait. But if you see fetal hemoglobin coming more than 90%, then that is going to be beta thal major. I mean the 4 most important hemoglobins and the way you diagnose them, the diseases are written over here. You've done the anemia trait, you've done the anemia and the trait, thal and sickle ka both. But is this the gold standard? No, because the gold standard stands as HPLC. That is whether it is for asked for sickle cell anemia, whether it is asked for thalassemia, it is always going to be HPLC. Now I tell you where you do an error. See, if I ask you that what is this a gold standard of? Ma'am, you want to know the type of hemoglobin, this is the gold standard. You want to know hemoglobin A, F, S, A2, koi bhi hemoglobin, this is the gold standard. But is this the gold standard for thalassemia? Hemoglobin, yes. Sickle cell, hemoglobin, yes. But for the disease, if I write genetics, if I say globin chain analysis, do you think that is better or HPLC is better? I mean, if I pick up the root cause, what can beat genetics? Nothing. So if they say globin chain sequencing, I mean, don't be stupid over there कि मैम ने HPLC पढ़ाया था, I will mark HPLC. When genetics comes in the question, then everything is left behind. This will only tell you the type of hemoglobin, but globin gene sequencing will tell you the problem in the globin gene. It will exactly tell you the genetic alteration. Nothing can beat. Then this becomes the gold standard. Please, please, you are not going to mess up on this. I am sure you will be good with it. Moving on to the next question. I have helped you a little by writing the diagnosis of the photo over here because I think I was confident you would be able to do that. Now tell me, there's a 27-year-old primary gravida showing the following blood picture on peripheral smear analysis. How will you investigate the patient further? How will you investigate the patient further? Okay, osmotic fragility, hereditary spherocytosis. Do you expect a 27-year-old to know when she's in her first pregnancy that she is suffering from hereditary spherocytosis and she has not known this for first 27 years of her life? Doesn't that sound a little too weird? Because hereditary spherocytosis will have splenomegaly, jaundice, bilirubin, gallstones. She's not known this for 27 years without treating it and curing it, or not curing but at least doing something about it. She's gotten pregnant. Seems a little weird, right? Because all of you just saw spherocytes and that is the easiest option to mark. I mean, anyone would do that, but that's why it's option A. The correct answer over here is Coombs test. See guys, when they write spherocytes, the second cause is hereditary spherocytosis always. And never mark hereditary spherocytosis unless you are given a family history, because this is an autosomal dominant disorder. They will say father, mother, brother, someone has it. Most common cause is autoimmune hemolytic anemia. Autoimmune hemolytic anemia is the most common cause, and that is going to show spherocytes most commonly that I can see over here. And for this you will do, see, autoimmune antibodies. What test will you do in her? You will do the Coombs test. So the answer to this question is Coombs test. That is one question. I want to change the question. Same photo, same options. Look at the next question over here. Now you have a 16-year-old boy with jaundice and splenomegaly. Same complaints are present in the elder brother and the mother, indicating an autosomal dominant inheritance in the family. How will you now show the investigation on this peripheral smear? Ma'am, now I think my first answer comes into play, that is osmotic fragility testing for hereditary spherocytosis. Now that is making sense. So question 1 and question 2, is that okay? Because all of you are very used to doing spherocyte HS khatam. No guys, family history hoga to HS. If it is not a family history, most common cause autoimmune hemolytic anemia. For autoimmune hemolytic anemia, you will do a Coombs test. For HS, as all of you told me, you will do osmotic fragility. Give me a third cause also. Spherocytes are also seen in G6PD deficiency. Why can't be B in question 1? That is the answer. B ही तो है ना. Question 1 का answer B ही तो है. Primary gravida, autoimmune hemolytic anemia, Coombs test. Question 2 का answer is osmotic fragility. I want to talk about it in a little bit detail. Autoimmune hemolytic anemia में तो you have done a Coombs test, but in HS you are saying family history will be there. Why? Because this is an autosomal dominant situation. What kind of a mutation is most commonly seen? Most common mutation that you see in HS is what, guys? It is going to be N-chirin. Because you said that it is most commonly autosomal dominant, but nothing is 100% in genetics na. It is most commonly autosomal dominant. Some 20-25% cases can be autosomal recessive, and those cases are damn severe. So the mutation in very severe or autosomal recessive type of HS is going to be spectrin. Please exam mein pad lena. If they just ask you simple question, N-chirin answer. If they say severe disease, autosomal recessive disease, then your answer becomes spectrin. And all of you were saying that the RBCs are going to become spherical, exactly how we have written it over here. So yes, they become spherical. And how are they removed? They are going to be destroyed by the spleen. You know, spleen ko bolte hain graveyard. That spleen is the one that is destroying everything. So now what can I do? Can I treat the genetics? I can't. Patient is born with it and will die with it. But what can I do for the treatment? I can definitely do splenectomy. You know the questions of splenectomy. Before doing a splenectomy, what will you do? Ma'am, we will do a vaccination of capsulated organism. After splenectomy, which bodies can be seen? The happy and jolly to be single bodies, that is Howell jolly bodies. ये तो हम पहले से पढ़ चुके हैं. But now my question is that what are the tests that are done for HS? You know, osmotic fragility testing, no one is going to ask you because that is a screening test. But when they talk about the definitive test, what is the new test which is characteristic diagnostic, uska full form batao? It is eosin 5 malamide testing. It is eosin 5 malamide testing. That is what is the diagnostic final test that you have for hereditary spherocytosis. Before I move forward, I had a question. Dr. Dhwani, yes, Coombs test is not just done for autoimmune hemolytic anemia. Coombs test is done wherever you want to know antibodies. If there is an ABO incompatibility, if there is an RH incompatibility, if there is any mother and fetus incompatibility, antibody fight happening, and Coombs test can be done for any antibody disorder that you want to find out. Okay. Now coming back, so now I have done autoimmune hemolytic anemia ka Coombs test, HS ka OFT, but now no one does OFT. Now ma'am, what is done is eosin 5 malamide testing, splenectomy kar denge. What if it was a case of G6PD and they would have shown you this? Would a family history come then also? Yes, because G6PD deficiency anemia is XLR. But how does G6PD deficiency anemia manifest? And that is exactly what they are going to ask you. So over here, the most common trigger, see G6PD ma'am XLR hai, genetically hai, by birth hai. But it is not going to manifest all the time. G6PD deficiency, who will tell me why does it occur? Most common trigger. When does it start manifesting? When will you start seeing symptoms in the patient? Is it because of consumption of fava beans? Yes, ma'am, in Mediterranean region, when people consume fava beans, their G6PD suddenly flares up. When they start consuming Prima Queen, anti-malarial drugs, their G6PD deficiency starts coming up. But no one told me. You are Q-Bank champions. You have seen this in every Q-Bank. Come on, guys. The most common trigger is infections. I have highlighted this in the version 6 RR videos also, and it's been a considerable while, hoping that you've seen them. It's been pretty a lot, almost a year now that those videos were uploaded. So the most common trigger is what? Infections. Yes. After that, all these Prima Queen. See, Prima Queen and fava beans are your favorite histories, but that's not the favorite trigger. The favorite trigger is going to be infections, usually viral infections. And now you know G6PD deficiency shows you which cells. You've done this. The dog bite, that is the degmacytes or the bite cells, and which bodies? This also you have done. Heinz bodies, wo kharab wala hemoglobin. Can you stain Heinz bodies on a Romanovsky stain? No, you cannot. What will you be using? We'll be using the classical crystal violet. What family of stains is crystal violet coming under? Is a supravital stain. Acha, for the diagnosis of G6 G6PD, firstly, the peripheral smear as you studied, ma'am, will show you spherocytes. And for the diagnosis, you are not going to do any fancy test. You are just going to measure G6PD levels. This is so simple. Like for iron deficiency, you do iron levels. For B12 deficiency, you do B12 levels. For G6PD deficiency, you do G6PD levels, and keep life simple over there. And that is the story. So I have taught you AIHA, HS and G6PD. Kaisa history aayega. Repeating once again, pregnant female, Coombs test related AIHA, family history, father, mother, brother having, it is HS, and they give you something to do with XLR, or they say fava beans, infections, anti-malarial drugs, bite cell ka photo diya, then you go in for G6PD deficiency. Is that okay? Spot test and all, Dr. PG target, हाँ करते हैं, but the final testing is done only by knowing the G6PD levels. Moving on to the next question, if I look at this question over here. Yeah, now let's see if you were listening to me. A child presents with intermittent jaundice and splenomegaly. There is a history of similar complaints in the elder brother. The peripheral smear shows the following finding. How will you investigate this patient? Someone said that the audio is breaking. Is there any issue with the audio, or can we continue? Okay, the audio seems to be working well at my end, guys, but now it's okay. ठीक चल रहा है? Okay, yes, now all good, it's fine. Okay, so just a small break that probably the technical wanted to take. Now we are back. Yeah, so what is this, guys? There's intermittent jaundice, splenomegaly, something similar in the elder brother also that is going to be there. So now this is a question which is pretty interesting. So I want you to answer this for me. Photo mein kya dikha? Photo mein, ma'am, I can see the same gol. I can see the same spherocytes. I can see the same spherocytes. What shall I mark? Okay, all of you are saying perfect. All of you are saying what? Some of you said osmotic fragility testing. Okay, no one said autoimmune hemolytic anemia because at least that is not genetic. This is the elder brother wala genetic. No one said paroxysmal nocturnal hemoglobinuria because nocturnal ka to history nahi hai. Plus, paroxysmal nocturnal hemoglobinuria is also acquired. It is not genetic. So now I have two options. I have genetic testing for G6PD and I have osmotic fragility testing. To be very honest, I could have thought of both. Again, the voice is breaking. Many of you have said that actually I can also see the voice at my end. Nothing is a problem. Probably some YouTube technical glitch. What everyone is doing is just exit and rejoin. But exit and do rejoin. Okay? That does not make you go back to some other social media. Exit and do join back. See, when they wrote intermittent is something, that is G6PD. So it comes and goes, That gave me a hint, maybe it is G6PD, but that is so intermittent that usually there is no time for a splenomegaly to occur. See, anti-malarial drugs someone will consume for 5 days, 10 days, chalo 15 days bhi kha liya. So that is not enough to cause splenomegaly. So that was not helping me. See, G6PD is XLR. XLR disorders are more commonly in men. This is mentioned again in the elder brother. But again, when I go by splenomegaly, that is not fitting with G6PD. So the single best answer goes over here in more commonality is osmotic fragility testing, and that is hereditary spherocytosis. But हाँ, G6PD का doubt तो हुआ, men में problem हो रहा है, intermittent mentioned है, but spleen नहीं होगा इतनी जल्दी in G6PD, plus no trigger, fava beans, anti-malarial, वो सब नहीं mentioned था. So I think this is certain that we are going for OFT and HS also over here. Now I've done too much of RBC, so now I will come to the favorite 10-star photo where you will tell me these cells, but you will tell me after I teach you. I'm being nice to you, teach you and then ask you. So that means I'm teaching you what is the normal TLC कितना होता है. Normal TLC is going to be 4,000 to 11,000. Simple question. And I made a cute little monkey on the side, which you all know, never let monkeys eat bananas, because from maximum to minimum is going to be NLMEB, right? NLMEB. So we have number 1 is going to be the neutrophils. Guys, neutrophils are identified how? They have 3 to 5 lobes, like this neutrophil has 3 lobes. Did I teach you where are there more number of lobes? Hypersegmented neutrophils are seen in megaloblastic anemia. Abhi pad liya, ma'am. Then we come to simple, sober looking, Sharif cell, round cell, round nucleus, lymphocyte. Ye koi nahi puchega. They will ask you, where do you see a lymphocyte which is looking like this? As if this is like a ballet skirt happening over here. What is this, guys? Yes? Tell me guys, this is what? This is a case of downy cell. Downy cell is the cell which shows you it's a lymphocyte, but some changes have occurred, and that change is going to be a ballerina skirt appearance. Now ballerina skirt appearance or downy cell is seen in EBVC. Instead of looking nice and round and sharif, what has it started looking? It has started looking like a ballet skirt flaring. Remember, I will teach you this once again when we go to virology chapter. Next, the monocyte. Monocyte is identified by the kidney-shaped nucleus, and the season coming up very soon, monocyte will be elevated in which infection? In cases of malaria. Excellent. Coming to eosinophil, the season which is going on right now, the season of allergies, because it's a season change, pollen, so allergy happening. Eosinophil is easiest to identify because this is the only orange color looking cell, and it is going to have a spectacle-shaped nucleus. Very good. And eosinophils will increase where? In any kind of allergy and any parasitic infection. Means favorite question. They will say there is a child who is having hookworm infection. Now with hookworm infection, there are only two clinical histories that they can give me. If they are asking anemia, with hookworm I have taught you is iron deficiency anemia, and if they ask me which cell in the white blood cells will increase, because it's a parasite, it will increase eosinophil. Eosinophil pe ek aur question, which is the interleukin which causes eosinophil activation? Interleukin 1, 2, 3, 4, 5, your options. Ma'am, eosinophil A, B, C, D, E will be 1, 2, 3, 4, 5. E is the fifth alphabet. Interleukin 5 causes eosinophil activation. Coming to the next, what is the last cell? B for basophil, B for blue-black, kuch dikh hi nahi raha, it is entirely covered with blue, black granules. So where is it increased? Two conditions which I will teach you today. One is CML, Philadelphia chromosome wala, usme basophils increase. And second is polycythemia vera. Many of you will believe polycythemia vera is polycythemia means RBC is more, hemoglobin is more and all of that, but there is also an increase in basophils. Now, what is the special stain for basophils? I told you for basophils and mast cells, what is the special stain? It is toluidine blue, supravital stain. Ye to hum pad chuke hain, ma'am. We already know this. So now if I ask you, this is the only photo on the internet and in the books where all the cells are given in one page. So you will only get this photo now, obviously. If I randomly ask you, this blue, black wala cell will become what? That will be a basophil. Obviously, then this orangish color cell will be what? That is going to be eosinophil. Simple, sober looking cell, round, sab kuch badhiya, that is going to be lymphocyte. Then you have a cell which has certain lobes. This so no one can go wrong even in their sleep, that is neutrophil. And then the left, which is left over here, is a kidney shape wala, that is known as monocyte. So if they give you 1, 2, 3, 4, 5 likha hoga, they will say, tell us what are these cells. This is also another cell over here called band cell, but they usually don't ask you. You can take a skip. Thoda exam mein smart ban jana hai. Instead of kidney shaped, they write reniform nucleus, bean shaped nucleus, right? These kind of words mean the same. I'm sure you are smart ones. You will be able to handle it. So this is a question. Don't think, arey, itna simple question aata hai. Whether it is INI, NEET or FMG, this question, this slide comes in every exam in some format or the other. Now I want to move forward and I want to ask you that, okay, where are these NLMEB coming from? So they are coming on from here. Plasma cell, thoda sa wait kar le, because maybe I have a question ahead. Moving on over here, where are these cells coming from? Ma'am, they are coming from blasts. Now, if I write NLMEB, these are the 5 cells, we have 3 blasts. See, we have lymphoblast. Obviously, lymphoblast will give rise to what? Lymphocyte. Then we have monoblast. Monoblast will give rise to what? Monocyte. And then we have myeloblast, because myeloblast gives rise to your favorite organization, that is NBE, means neutrophil, basophil and eosinophil. So your favorite organization NBE comes from myeloblast. Okay, so now I have to know the difference between a myeloblast and a lymphoblast. Myeloblast is identified by this abundance of OR rods which you can see over here. Lots and lots of OR rods. NEET PG mein question aata hai, OR rods are going to be an aggregation of which granules? They are an aggregation of the lysosomal granules, previous year question. So myeloblast will have the OR rod and lymphoblast will not have the OR rod. Ye to sabko pata tha na? Now you will tell me their special stain. What is the special stain for myeloblast? Most important stain, common sense ma'am. Myeloblast ke liye myeloperoxidase most common, and lymphoblast ke liye the most common you had told me yesterday also. Pass positivity. Remember we made a table of pass positivity, and I'll remind you once again, only glycogen was pass positive diastase sensitive. After that, whatever list you give me, you try to give me an ABCD wala list. A say you told me alpha 1 antitrypsin deficiency, B say you told me basement membrane, then with D you were trying to, all those things. I hope you remember all of that. Yes, you've not forgotten. In diabetes, like you were telling me, then in lymphoblast and in Whipple's disease also you told me pass positive, and then you said diastase resistant hota hai. In case you've forgotten, matlab you have not revised yesterday's class, so I'm not repeating it. It is a beautiful slide we have made in yesterday's class. Pass positivity revision karke aana. Now, I want to ask you a very simple question which is put up on the next slide, which is somehow not getting projected, but I will come down to it. This question, I have somewhere written the answer, reason being it's from your previous LRR, but let's make you first read through this question, then I'll come back to answer. Sabko pata hai because the same question is from the last LRR. Now there's a 5-year-old boy who's presented with a 1-month history of loss of appetite, fatigability, irritability and low grade fever. Now the questions of leukemias, before I start, leukemia के दो question, मैम acute leukemia, chronic leukemia. तो मुझे exam में जाके ना there are question is not going to come to me. I will have to search my things in the question. If I say that the blast count is going to be equal to more than 20%, I will start thinking of acute leukemias. And if it is less than 20%, I will start thinking of chronic leukemias. If I skip the entire question and I say that there is a bone marrow which is showing me 30% of the bone marrow as lymphoblast, more than 20% lymphoblast, answer ALL ban chuka hai. It is acute lymphoblastic leukemia. So blast count is the first thing. Now whatever will be the acute leukemia, it could be ALL or it could be AML. Leukemias have a property. What is it? It's a cancer. And listen to me for exactly a minute. Cancer will only show you cancer cells everywhere. Blast, 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 blast. Where will the normal cells go? They will be missing. So RBCs will go down. Patient will have all anemia related features. Then the normal WBCs, where did the neutrophils go, ma'am? The monocytes, the basophils, they have all gone. That is the patient is having infections. Where will the platelet go? It will go down. Patient will have bleeding. So if you look carefully, patient is having fever again and again because normal WBCs are not there. Thereafter, patient has bone pain in the lower extremities. Then there is generalized pallor, which is obvious because RBC count is low. There is splenomegaly, lymphadenopathy. You can see hemoglobin come ho gaya. Total white blood cell count might increase, but the normal cells won't. Why has that count increased? Because these are all blast things. Now look at the platelet count, guys. What is the normal platelet count? 1.5 to 4.5 lakhs. Platelet count has come to 90,000. So when there is suppression of everything in the bone marrow, I will think, acha, everything is going down. Cancer is growing. And more than 30% lymphoblast is ALL. Watch out for these kind of histories. Now in ALL, they will ask you, which are the chromosomal abnormalities which is most commonly associated with this patient is going to be hyperdiploidy. All of these are associated with this patient. How do we learn the genetics of ALL? Ma'am, ALL, 3 alphabets, anything that will sum up to 3, total uska 3 aa jayega add karne pe, I will know that it is good for the patient. It is going to have a good prognosis. So when I write hyperdiploidy, diploidy means 2n, hyper means more than 2n, which is 3n, that is good for the patient. All trisomies having 3 chromosomes, that is good for the patient. So trisomy 4, 4 plus 3, 7, 7 plus 3, 10. Everywhere you will read plus 3, 3, 3. Then translocation 1, 2, 2, 1. Add 1 plus 2, 3. Add 2 plus 1, 3. Ma'am, har jagah 3, 3, 3 aaya. So, matlab this is all going to be what? This is going to be good prognosis. Where the 3 is not coming, hypodiploidy means less than 2n. That is bad. Translocation 922, that is bad. But have I studied translocation 922 somewhere else? This is specially for NEET PG and INI-CET students. When they say translocation 922, which are the chromosome genes that you are trying to fuse? It is BCR ABL fusion. Very good. So ma'am, whenever we think of this, we think of CML na, Philadelphia sochte hain pehle. Why are you writing ALL mein? Why are you writing this? Because now for NEET and INI-CET students, please note, you have to know the weight of this protein. How much has the fusion resulted in a weight of how much of protein? It could be you start with 190 kilodalton, then you add a 20, you come to 210 kilodalton, you add another 20, you come to 230 kilodalton, and that will make it ALL, CML and CNL. How should I learn this? First you will have to write the weight, 20 ke gap pe, 190 kilodalton, 210 kilodalton, 230 kilodalton, and then you will write alphabetical order L, MN. These are the three leukemias that occur. Number one is going to be ALL. Second one is going to be Philadelphia, CML, and third one is going to be chronic neutrophilic leukemia, that is CNL. This has been asked, but now I want to tell you that aap most commonly padhte ho in case of CML, and over there it is going to have a good prognosis. But when it happens in ALL, over here I just now taught you, it is going to have a bad prognosis, and that is what you've written over here. You have written it under the bad prognosis. I think we are settled with this. Can we move on to the next question? These are all the AMLs that I have written for you. I have been kind enough, written their names, written their options. You have to select which AML I am talking about, because options are all to do with AMLs. Starting with a 15-year-old boy with one history of bleeding gums, and be very cautious, don't be in any hurry. Bleeding gums, subconjunctival bleed and purpuric rash. हर जगह blood जा रहा है. And when ma'am, usually what happens when we read bleeding gums देख के we start thinking of AML M4 and M5. Because AML M4 and M5 are known to cause tissue infiltration, and one of the tissue that they go into is going to be gum. So we feel acha gum hypertrophy hua hai, bleeding gums hua hai, it is AML M4 M5. But then it's not just bleeding gums, it's bleeding everywhere, and bleeding everywhere because look at the platelet count, it has gone all the way down to 35,000. Not just that, look at the prothrombin time and the APTT. Guys, normal prothrombin time is 11 to 15 16 seconds tak, and normal APTT is going to be roughly 25 to 35 seconds, maybe a little till 40 seconds chalega. But over here I saw that the PT is also increased and the APTT is also increased. Now tell me that when the PT is increased and the APTT is increased, matlab full clotting pathway has gone for a toss. It is totally spoiled. On top of that, the platelet count is also decreasing. This is a classical case of DIC, and the only leukemia which is associated with DIC is going to be AML M3. See, the safest guess you can take in the exam is always AML M3, because maximum questions are coming up from there. I'll come back to that chart. Number one, if they ask you where do you see maximum OR rods, so many of them, they are all showing crisscross in them. What are these crisscross OR rods known as? That is referred to as the faggot cells. Where are faggot cells seen? AML M3. Where are maximum OR rods seen? AML M3. Which is the leukemia associated with DIC? AML M3. So what is the translocation? Translocation is 1517, and all of you have already written for me that this shows me the PML RARA fusion. It shows me the PML RARA fusion. RARA matlab retinoic acid. Ma'am, this tumor is happening because of a problem in vitamin A metabolism. So if the problem is in retinoic acid, then the treatment should also be retinoic acid. We give ATRA, that is all trans retinoic acid. Along with that, we are going to give arsenic trioxide. Do we give chemotherapy? No. In this, usually chemotherapy is not advised, because on giving chemotherapy, usually the patient starts showing complications of DIC and ends up dying. Chemotherapy is not the first line of action. It is ATRA plus arsenic trioxide. Why ATRA? Because the problem in the genetics is also in the retinoic acid only. Now you will tell me that out of all these, ma'am, that table you have written once again, सिर्फ जो सबसे important वाले M2, M3, M4 के translocations हैं, you will tell me. Translocation 821 is seen in AML M2. Translocation 1517 is seen in AML M3. So nice, you guys know it. And then inversion 16 is going to be seen in AML M4. We've learnt it as mathematics. So LCM निकालते थे ना, multiples करते थे. We are going to take out multiples. So we say 4, okay, 4 4s are 16. So this goes very well. Then if I'm confused, where does the 8 go and where does the 15 go? So with 2 I can take a multiple of 8, and with 3 I can take a multiple of 15, because they give you match the following out here. So remember, with 4 4s you will go for 16, with 2 you will go for 8, with 3 you will go for 15. Why did I make you learn for these three only? Because these are the only three AMLs which have a good prognosis. Question number 1, AML M2, M3, M4, these genetics are good. Question number 2, when these genetics come into account, will you look at the blast count? You told me, ma'am, for acute leukemia, AML blast count should be more than 20%. But will you look at the blast count, or are these diagnoses made irrespective of blast count? Remember, if I have a patient and I say inversion 16 hai, proven, then whether the blast count is 1, 2, 5 or 100, I don't care. It is a case of AML. In these three situations, if these three reports are in front of you, any of them, don't bother about the blast count. Less than 20, more than 20, I don't care. These three reports are in front of me, diagnosis is going to be a case of AML irrespectively. Okay, if I move forward and come back, this was a case of DIC, that is why the answer was M3. Bleeding gums ki wajah se my differential diagnosis was M4, M5, but in the end DIC made it as M3. Out of these, which is the most common? The most common one is this AML M2 and the least common one is going to be AML M7. When does AML M7 become the most common? वैसे तो it is least common, but it can become most common in a case of Down syndrome if the child, not overall. Every time in Down syndrome, it is not AML M7, which asks me another, which makes comes me to another question, makes me come to another question. That is Down syndrome, the most common leukemia overall asked is ALL. But if I ask you the Down's baby is less than 3 years of age, now my answer is AML M7. So please be very certain that overall in general population, AML M7 is not at all common. But if you have a Down's baby less than 3 years of age, then AML M7 becomes the most common. They will not write AML M7 in the exam. They will write M7 ka pura naam. M7 out of these is the biggest number and has the biggest name, mega name. Acute megakaryoblast leukemia is the name that we have, and I can see everyone. Learning versus mugging up versus imprinting. 3 stages होती है पता है. Learning, then the next stage is that you know as it is, whatever I taught you, you mugged it up, and third is you took the copy and then you made a photocopy printing into your brain, and that is what you've done, guys, which is great, and just keep up the momentum. Okay, M6, we don't get questions on it, but earlier they used to say this is, you know, a kind of an erythroblastic leukemia, but now they call it acute. Wording has changed, pure erythroid leukemia. There are certain syndromes, but not important even for INI-CET, they would not be asked. The criteria is usually when more than 50% erythroblasts are there, but someone asked me, it's not important, so don't get into that, it will get too much detailed. Now moving on to the next question. Again, a new question which I got from the Q Bank. There's a 65-year-old male presents with chronic fatigue and lymphadenopathy and presents to the outpatient department. So one thing is certain, here I have an elderly patient. Now the peripheral smear shows the presence of smudge cells. Ma'am, as soon as you say smudge cells, hamara answer ready hai. Our answer is CLL. We don't think much. What will you do to arrive at a diagnosis? What is your investigation for CLL that you would want to do? I think you couldn't see the options. Now you can. What would you want to do? The criteria. Many of you are saying flow cytometry, and before you ask every day on Telegram, I get this question every week. Today I am giving you that entire list. For which leukemia, which investigation will you do? But first tell me, I am talking about CLL. CLL is referred to as the college or college girl appearance will come later. CLL is referred to as the convent school girl appearance. CLL is referred to as the convent school girl. Why? Because all of them are in the same uniform. CLL is the convent school girl appearance, because you will tell me where do you see the college girl appearance that is seen in case of CML, जो बाद में देखेंगे. अभी के लिए convent school girl appearance is because uniform ना, all lymphocyte, ma'am, that is exactly what you said. This is only and only lymphocytes. Now you will tell me a criteria. Very good, you've given me the exact same protocol. सबसे पहले what do? We do lymphocyte count. How much should be the lymphocyte count? More than 5,000 per mm cube. So nice, you know it. You do a blood test in a 75-year-old uncle, and his blood test shows lymphocyte count is more than 5,000. The next step would be flow cytometry or bone marrow is the question asked, and the next step would be flow cytometry. See, you already have his blood sample. Don't give him more pain by calling him directly for a bone marrow. What sample you have, do your job well. From the same sample, run it in a different machine without troubling the patient. On flow cytometry, you should get sab kuch positive. 5 positive, 23 positive and 200 positive. Everything comes positive in CLL. And then when it comes positive, after that you will call him for a bone marrow testing. And bone marrow lymphocytes will be more than, very good, 30%. It's in the same order. First you do the blood test. From the same blood sample, without pricking the patient again, without giving him pain, you do a flow cytometry. Now when these two criteria have been fulfilled, now you can give him more pain if you have to, and now you will go into bone marrow testing more than 30%. So here they asked you what will you do? I would do a Flow cytometry. Can you do some genetics also? Yes, I can do cytogenetics, because the most common genetics in CLL is what? It is going to be deletion 13q. And in INI-CET exam, they will write this chromosome 13. This is the short arm, this is the long arm. They will say, okay, 13q is getting deleted. But exactly which part of 13q is getting deleted? INI-CET students, it is microRNA 15 and 16 which is getting deleted. That could be a question for you guys. It is microRNA 15 and 16. Now coming back, that after this is done, genetics is done, what all syndromes can a person suffer from? Abhi I'm not going into other things. CML करने के बाद I will tell you किसके लिए fish था, किसके लिए PCR etc. Now I come to syndromes. What is Evans? Ma'am, Evans is everyone. Everyone ka syndrome is Evans syndrome. Everyone means that in the RBC, WBC and platelet, everyone is going to go for a toss. WBC, to we know, is a case of leukemia. Along with that, if the patient has warm type of autoimmune hemolytic anemia, and I'm not writing it, if it is autoimmune hemolytic anemia, you will do Coombs test, because you are seeing spherocytes. Ye to pad liya. Warm means which antibody? Because this mnemonic is universally known. Warm is garam, IgG antibody causes it. And along with that, if the platelet count goes down, that is ITP, that is going to be a case of everyone gone. Everyone matlab Evans syndrome. Second can be rich. Rich means a small person becomes a big person. So CLL can have a lymphoma component called small lymphoma. This small lymphoma decides that I want to become a big person, DLBCL, I want to become a large lymphoma. So when a small chota admi becoming bada admi, small person becoming big person, he is becoming rich, that is known as Richter syndrome. Sorry to ask you a very, very unrelated question, but I want to. That is, what is Rick's focus? Because rich word se mujhe bas aisi randomly yaad aa gaya, it wasn't planned. Rick's focus is studied where? Richter syndrome to you studied. Where do you see Rick's focus, guys? Because somewhere in TB. Which part of TB? Or which organ of TB is called? Very good. TB in the brain focus of TB is called the Rick's focus. We've always studied brainy people will be rich in the future, right? That's, I don't think, because then doctors should have been the richest, but nonetheless, it is said that brainy people are rich people. So we learn it that ways. Coming to Richter syndrome also that we have studied. Now let's move forward a little and talk about the next question, which tells me a very classical thing. There is a 45-year-old patient complaining of fatigue, dragging sensation in the abdomen. ये इनका favorite. मतलब हमारे ना final year के clinical posting से we can never write spleen is enlarged, because spleen enlargement is our language, patient का language. Indian patients don't come to us saying dragging sensation, but then we have to write it in English like that. Dragging sensation will always give you an indication that there is some spleen enlargement happened. Spleen enlargement, and they tell you infection. I'm not reading the question. Infection, I will always think of Kala Azar, right? All of you have gone to the answer, and I know you know the answer, so I'm not focusing on that. Kala Azar, history of patient from Bihar, Orissa, Jharkhand. Kala Azar means what? Leishmania donovani, LD bodies ka kuch hoga, which ma'am we will study in the micro LRR. Other than that, if they talk about leukemia, always think of CML, and going forward I will also teach you hairy cell leukemia. In dono ka sochna hi sochna. Over here they found that there is massive splenomegaly, which is obvious. Blood work shows hemoglobin has gone down. Look at the TLC, 1 lakh. It is supposed to be 4,000 to 11,000. This is 1,75,000. It's huge. Now the peripheral smear shows lots of leukocytes with shift to left. So many questions I get on what is shift to left. Shift to left means I've started seeing immature cells, and bone marrow shows me all those immature cells: myeloblasts, myelocytes, metamyelocytes, neutrophils, basophils. Full garden party happening, ma'am. College girl garden party. Everyone is wearing different beautiful clothes. Everyone is looking different. That is CML. Before this, everyone was looking the same. Convent school girl, lymphocyte. That was what? That was a case of CLL. Here everyone is looking different. CML. This is a classical case of CML. And you studied translocation 922. You will tell me what is the weight of BCR-ABL, 190, 210 or 230. We just studied. It is going to be 210 kilodalton. What is the prognosis? The prognosis is good. Treatment तो मैंने कल ही बता दिया था. When BCR and ABL fusion happens, there is an increase in tyrosine kinase. Therefore, for the treatment, I would want to give tyrosine kinase inhibitor, which is going to be imatinib. Ma'am, you told us yesterday, and you made a chota little table for us that imatinib is given only in 2 places in pathology, in medicine, in surgery, wherever. One is CML, and what was that gastric tumor where we studied it? It was gist. So this is done. But again, if someone asks you, ये सब तो ठीक है, ये सब तो slide पे देख लिया and all of that, investigation of choice will be looking at this translocation, and to look at this translocation I will do a technique which is known as fish. This is how fish looks like. This I'm teaching you from genetics point of view also. What is this, guys? This is going to be fish, and fish में ना best is, I hope you get multiple 10 questions on fish you get, because you don't have to do anything in fish. सारा काम examiner का होता है. Examiner has to tell you, okay, red color has been given to ABL, okay, green color has been given to BCR. ये सब examiner's headache. I just have to do like a baby red, green. So I noticed that, okay, I will have 2 copies of ABL. Any normal person has two copies. And I will have 2 copies of BCR normal. This is a normal cell, 2 red, 2 green, ठीक है. Over here I can see only 1 red and 1 green, 1 red and 1 green, 1 red and 1 green. Why? Because the other red and green have gotten fused. यही तो है. Translocation 922 has happened. They have gotten fused. How easy. I wish you get to see this. You get 10 questions on this because it's the easiest. कुछ तो examiner भी करेगा. We don't have to study anything. For INI-CET students, the questions asked is that for fish, which phase of cells is it kept in? Prophase, metaphase, anaphase, telophase, interphase. So for fish, usually it is the interphase cell phase of the cells which it is kept in. For fish, what sample? Dr. Amit, that depends. If you're dealing with the case of CML, you could either have a blood sample or a bone marrow sample. I mean, whatever sample you get from the patient, either it's a blood or it's a bone marrow. Jahan cancer cell dikh raha, you take. If you want to do fish, let's say for breast cancer, then you're getting breast cancer biopsy samples and then you're running those. I mean, the cancer will vary from patient to patient and the sample will also vary, but the cell has to be kept at which phase? It has to be kept at interphase. Now let me move to the question that came in INI-CET. Same screenshot I have got you in your rapid revision also. The fish is used for the diagnosis of all except. Means, ma'am, fish is something which is being used for chromosomal disorders. I'm sure this black background is giving you rapid revision vibes again. Nostalgia. So chromosomal disorders, whether the chromosomes are amplified, genes are amplified, or the chromosomes are getting deleted, like say, what is catch 22? What is deletion chromosome 22? Just randomly, whichever deletion came to my mind. So tell me, guys, what is deletion 22, catch 22, Dye-George syndrome that you study in pediatrics? That can be detected using fish. Okay, then if I say translocation, ma'am, translocation can also be detected. जैसे अभी Philadelphia chromosome, what cannot be detected is point mutation, because point mutation के लिए what is done? PCR is going to be done. Perfect. अच्छा, now that you guys have been so nice and you've told me the deletion, I want to ask you 2 things. Like you said, deletion 22, ma'am, वो catch 22 का Dye-George syndrome था. एक deletion 3p is also asked. Which syndrome comes under deletion 3p? I mean, it's a very random question, but then where will I teach you otherwise? Deletion 3p, 3 chromosome deleted, 3 alphabet wala syndrome is going to be VHL syndrome. Yeah, these are just 2 random deletions that popped up in my mind right now, and I think you should be knowing it. Before I move forward, very good. Random questions bhi aa rahe hain, great. And trust me, when I'm saying and I'm praising you all, it is not that I'm trying to give you any kind of pseudo confidence. I don't want to be a pseudo rosette in your life. I'm truly being a true rosette, because I want to tell you that pathology, even if you go topic wise, is very difficult to recall. Randomly to bhul jao. And when you are recalling it randomly, it is not that I'm trying to give you pseudo confidence. It is genuinely a matter of fact that you need to give a pat on your back, because it's not everyone's cup of cake. It is very, very tough. That extra cherry on the cake that you have added, it is very, very good. Trust me. Before that, AML, CML, CLL and CML. 4, okay, I also, it's like a tongue twister. What is their investigation of choice? Ma'am, for ALL, I think CD markers pata kar lo, so flow cytometry will work well. For CLL also you had to do CD markers, so flow cytometry will also work well. AML में भी तो CD markers हैं, तो flow cytometry will work well. But there is one that DIC वाला leukemia, that is AML M3. Over there you've always said कि अच्छा 15, 17 तो ज़रूर पता करना. So over there I think when you want to know about chromosomes, I think fish will be a better investigation of choice. Lastly, when I say CML, Over here also I think translocation 922 Philadelphia I want to know. So fish will be the investigation of choice. Now I have not put in any rocket science. I don't know why all of you keep asking me, ma'am please table bana do, notes de do, flashcard de do. It is so simple. Wherever you are dealing with blasts or any kind of blood cells, you want to do flow cytometry, CD markers, na? CD5, CD10, CD20, CD markers. What are the two places you want to know translocations? In AML M3 I want to do translocation 15, 17. In CML I want to do Philadelphia chromosome translocation 922. So in those jagah I will be using fish. Okay. Now coming on to the next one is this question, which I think was much needed, a breath of fresh air, just something very away from leukemias. A 40-year-old patient, any questions? M2 also translocation, yes Dr. Dhanashri, but we usually do it better with CD markers also, it can be diagnosed. For AML M3 it is very essential to prove it, because over there you have to give ATRA, right? So for there the investigation of choice is fish. Now, and CD markers don't help too much. So after studies they found that fish helps better. Fine, coming back, 40-year-old patient presents with cervical and inguinal lymphadenopathy, complaining of cough and weight loss since the past 4 months. Excision biopsy of the cervical lymph node shows large atypical cells with mirror image nuclei showing owl-eye appearance. I have been a very nice, kind-hearted flexner intestine, true rosette, and I wrote owl-eye appearance. Examiner will cut this line for you and will only write mirror image nuclei, which means it is the same thing. These mirror image that look the same, they will not write owl-eye. He's not that nice in the exam. You still have to figure out owl-eye, mirror image nuclei, and there is a mixed background. So many things. Eosinophils, plasma cells, plus they are positive for 15 and 30. Ma'am, these are classical Reed-Sternberg cells with so many mixture of cells. This must be mixed cellularity only. Although, if I go by overall, which is the most common Hodgkin's lymphoma in the world, worldwide it is nodular sclerosis which is more common. But when they said background has so many mixture of cells, the word mixed cellularity comes better to us. So when I just show you quickly the different Hodgkin's lymphoma, do we know there are two categories? One is classical, one is non-classical. Jaldi se 2 minutes mein we have to finish this revision. For classical Hodgkin's, what are the CD markers? It is going to be CD 15, 30 and PAX5. Okay, 15, 30 and PAX5. So double kara and PAX5. Out of them, which is the sensitive one is going to be CD 30 and which is the specific one is going to be PAX5. One question for NEET and INI students, ke PAX5 hota kya hai? What is PAX5 gene or PAX5 marker? This is a marker needed for B cell development. So whenever the examiner will give me a B cell related leukemia, lymphoma, he will mention PAX5, which gets me to the first question that I should have asked you. Hodgkin's lymphoma takes its origin from where? Is it a B cell lymphoma or a T cell lymphoma? Ma'am, obviously if you're talking about B cell PAX5, it is a post-germinal center B cell. It is a post-germinal center B cell that you have to know over here, and now that makes sense. It's arising from the B cell, and that's why it's going to be a PAX5 gene mutation that we have over here, and PAX5 gene is the most specific marker. Okay, so why did you divide it into classical and non-classical? I got my answer, because classical ones are associated with EBV. Their markers are 15, 30, PAX5. Non-classical one is not associated with EBV and its markers are different. What are the markers of non-classical? फिर कुछ doubling चलेगा. 20 का not double I would say, but somewhat double if you can believe. It is going to be 45. Then we have BCL6 and then we have EMA. I know these are not easy to learn, but sometimes you don't have an option in life. So coming back, classical ka EBV with alag markers, non-classical no EBV with alag markers. Now let's go into detail. Classical one is of 4 types. Nodular sclerosis, which I told you in the world, and MI for mixed cellularity is most common in India. Then we have the lymphocyte rich, too many lymphocytes, and then we have lymphocyte depleted, means no lymphocytes. How are their RS cells looking? Now the classical one that you see na, कि मैम वो जो owl eye वाला cell है, owl eye is kept for India. ठीक है, the owl eye, the ullu is kept for India. So the classical RS cell is kept for mixed cellularity, that is in India. Nodular sclerosis shows you lacunar RS cells. Basically, it's the same RS cell, but that RS cell is going to have a lacuna, a white area around it. That same owl-eye kind of RS cell with a white area around it is a lacunar RS cell. So is this lacuna a true lacuna, or is it going to be an artifact? This is going to be an artifact. It has been created. It is not a true lacuna that the patient has. Nodular, lacunar, rhyme kar gaya. Very good. Mixed cellularity, India wala, India mein ullu, so India mein owl, that is you're going to learn owl-eye. Then lymphocyte rich, too many lymphocytes, then the RS cell becomes mononuclear. Can you see originally the RS cell had two eyes, two nuclei, do nucleus, but now it will be with single eye. Okay, he's going to be a pirate, he's going to be single eye, that is going to be mononuclear RS cell. So this is how I give you one philosophy in the rapid revision videos also. If someone keeps running after money and trying to be only rich, he will lose out on all relationships, he will be left single. So rich and single is how this person is. Although that philosophy only works in rich is sad, yeah, that philosophy only works on paper. In life, however, it's never rich and single. But nonetheless, lymphocyte rich is going to be mononuclear. Lymphocyte depleted, all the lymphocytes have died. Lymphocyte bhi dead ho gaya, RS cell bhi dead ho gaya, ma'am, it has become a mummy. It is a mummified RS cell, and obviously this dead one is too much of dead. Patient ko bhi thoda death ki taraf le jate hain, unfortunately. The prognosis of this is going to be the worst. It's dead wala name, dead wala mummy RS cell, and dead wala patient is how we learn it. Now all of these were classical. Under non-classical, we have NLPHL. NLPHL is nodular lymphocyte predominant Hodgkin's lymphoma, which shows you popcorn RS cell. क्या देखोगे इसमें? It's looking like a popcorn. I mean, it's as obvious as the name. So popcorn RS cell. Yesterday I taught you radiology का popcorn calcification. ना? Remember that हमारा पैसा, हमारा popcorn, that story that we studied. So popcorn calcification was seen in pulmonary hamartoma. And popcorn calcification was seen in one breast tumor also, that is fibroadenoma, which we have written yesterday. Today we are doing popcorn RS cell, which is seen in the non-classical variety, that is NLPHL. So this is done. Now this popcorn, tasty popcorn, everyone's favorite, it is going to have the best prognosis for the patient. So now overall best prognosis पूछा तो popcorn. Overall, तो मैम सबसे tasty word in this table is popcorn only, so we love it. But out of these four, only in the classical, if they ask you which is the best prognosis, that is going to be the nodular sclerosis. So can I say nodular, दोनों तरफ are good? Nodular are always good, but which is the best wala? The popcorn wala nodular is the best. Nodular both are good, but popcorn wala nodular is the best, and the worst one is going to be the dead one, depleted mummy wala. Okay with everyone? Coming back, this Hodgkin's lymphoma was classical with mixed cellularity. The owl-eye was mentioned, CD1530 was mentioned. If they ask you which is the most specific marker, PYQs kar lo jaldi, I have only 10 seconds for this. Most specific marker kya hoga? Specific is going to be PAX5, pad liya. Next, where do you see lacunar RS cells, which is lacuna is what? Which is an artifact, real nahi hota ma'am. Lacunar, nodular, so that is going to be seen in nodular sclerosis, and this story is settled. Moving on to the next question, which is this. There is a 60-year-old male patient who has fatigue for the last 4 months. This is my favorite question. Every exam, I believe something around it is going to come, and this time the gut feeling is even higher. On physical examination, there is a massive spleen. Ma'am, you told us या तो काला आजार होगा. काला आजार तो ये नहीं लग रहा. No, nothing to do with काला आजार. Or it is CML, maybe that is one option. Or it is hairy cell leukemia. 3 options I have, and somewhere hairy cell leukemia is mentioned. Plus so many things. There is hemoglobin of 8, TLC has gone so low, platelet count has also gone so low. Peripheral examination shows some lymphoid cell positive for annexin A1. If they would have mentioned something to do with annexin 5, that is annexin 5, I would have called it apoptosis. If they write annexin A1, then we start thinking of hairy cell leukemia. Yes, apoptosis, annexin 5, hairy cell leukemia, annexin A1. Now they've asked you all are true except you've given me the right answer. See, fried egg appearance it shows you, but that is not on a bone marrow aspirate. That is going to be seen on a bone marrow biopsy. Did I teach you any brain tumor yesterday which was showing you fried egg appearance before I start with this entire story? It is oligodendroglioma is going to show you fried egg appearance. Hairy cell leukemia on a bone marrow biopsy shows you fried egg appearance. For our students for INI-CET exam, you should know that testicular and ovarian tumors also show you fried egg appearance, that is seminoma, dysgerminoma. And because I'm making my work easier, I will not teach you again in micro, time nahi hai. So there are 2 more microbioorganisms which show you fried egg appearance. Very good. Mycoplasma to answers mein aa chuka tha. Very good. The bacteria that shows you fried egg is mycoplasma, and one fungus also. Malassezia furfur, chalo, amazing. Ye bhi yaad hai. What more should I ask you? So Malassezia furfur also. This means I will not ask you again. Fried egg colonies of micro. यहीं पर खत्म कर दिया. But now let us read back. This is hairy cell leukemia. Do you remember hairy cell leukemia is that famous TikTok boy which they always tend to ask you? And we have studied how to be viral on social media. You need to have some expensive products to show off. You need to constantly post about how many grams of protein to have in a day. Even if you don't have knowledge, people are posting about it. And you are constantly dressing up in the most weird trends and making red hair and whatnot. So this is a viral TikTok boy, and that is exactly what is hairy cell leukemia. Firstly, you will always remember his hair, and that is why which cells do you see? We get to see hairy cells. Boys are more hairy, so this is most commonly seen in boys. Number one, if they ask you the mutation, this is a brat boy. He's a true brat. He's not at all studying. We always used to study in rapid revision that hairy cell leukemia is dabba gol, padhai mein dabba gol, and I will come to that also. First, he's a brat boy, that is BRAF V600E. Guys, the last slide that I taught you yesterday's LRR was also BRAF V600E. Can you quickly tell me, BRAF V600E comes in 4 very important places. Yesterday I taught you for papillary carcinoma thyroid, yes, most common mutation BRAF V600E, and one brain tumor also I taught you, that was pilocytic astrocytoma, that was also BRAF, so P and P. Today I am teaching you hairy cell leukemia, and if you read it opposite, it will become LCH, that is Langerhans cell histiocytosis. So all of these are going to be BRAF V600E positive. Now coming back, if I come down to what is the markers, so the markers may, first one ma'am, you have studied annexin A1, and apart from that, as I said, Dabba Gold DBA44 is going to be a new marker that has come up for hairy cell leukemia. CD markers are important only for NEET and INI-CET, not for FMG exam. CD markers are CD11, 25 and 103. CD11, 25 and 103, one in every series, 10s, 20s, then cross the century. 11, 25 and 103 only for NEET and INI-CET. Coming back, why did you tell us about this MacBook mentioned over here, ma'am? Because the most common infections that these patients have MAC. If you go back and notice, this patient's counts were so less, hemoglobin less, TLC less, platelet less, of course he's going to have infections. Which infections are most common? What is MAC? Not the MacBook shown here. Mycobacterium avium complex, TB ke bhai behan. Mycobacterium avium complex is the infection. How do these patients present? I told you, massive splenomegaly. Now the rule is that for all the leukemias and lymphomas, when I say spleen is involved, it is always the white pulp of the spleen that is going to get affected, which is common sense, na? Leukemia, lymphoma are white blood cell disorders, so white pulp of the spleen will get affected. But in hairy cell leukemia, it is the red pulp of the spleen that is going to get affected, hence the red-haired boy, which becomes very, very famous. Plus, now let's come to his bone marrow studies. When I look at the bone marrow of hairy cell leukemia, sorry, I always end up drawing a dog bone, but it's okay. So whenever you see this, you will notice that the bone marrow is having a lot of fibrosis. Hairy cells that were there, they have created a lot of fibrosis. If I put a needle, will I get any liquid part? Means if I put a bone marrow aspirate needle and try to take out liquid part, you won't get anything, ma'am. You will get a dry tap. Bone marrow aspirate, you get a dry tap. Therefore, what is investigation of choice? It is bone marrow biopsy. What does that show you? The fried egg appearance. And coming back, is it going to involve the red pulp of the spleen? Yes. Are MAC infections most common? Atypical mycobacteria? Yes. Is it going to show you the BRAF V600E mutation? Yes. But does it show fried egg? Yes. On a bone marrow aspirate? No. Bone marrow aspirate shows you dry tap. Bone marrow biopsy shows you the fried egg appearance. That is the story of hairy cell leukemia that you have to know. If you want to, someone asked me that, ma'am, I am not able to see hairy cells. They don't give you pictures of hairy cells, but if you have to see them, which microscopy can you best see them on? They are best seen on phase contrast microscopy that you have. Okay, someone asked me another question. Now you want to study the full topic only, aise to fir pad lo. What is the special stain? Special stain is going to be TRAP. TRAP stands for, who asked me this question? Dr. Sangeeta. It is tartrate resistant acid phosphatase. It's basically measuring an enzyme, acid phosphatase, and TRAP also gives you a red color. Hence we learn it as a red color TikTok boy, because red is the pulp that is involved in the spleen and red is the color that you get with TRAP. Is that okay? Annexin 5 doesn't come here. Now I've told you, Dr. Gaikwad, annexin 5 is for apoptosis. That's different. This is annexin A1. Wo to alag question tha. That is done. Now I move on, go on to the next question over here, which is just a second. Sorry, I think it's just taking a little bit of lag to download. Yeah. Okay. Forget the questions that I have handwritten. The question that I have asked is what I want you to answer. Large homogeneous intracytoplasmic inclusions in plasma cells are called as what? All this you will answer later on. First, you will tell me this. Large cytoplasmic inclusions. See, you're saying Russell bodies? Okay. Yes, as soon as I say plasma cells, what are you thinking of multiple myeloma? Did I just now teach you this question? Whether it is anemia of chronic disease, or it is COVID, or it is multiple myeloma, which interleukin was helping in all of these? Ma'am, it was interleukin 6. Abhi bas 1 hour back you have taught us, okay? Next, how does multiple myeloma present? It is usually a 70-year-old uncle or auntie, so one elderly person will be mentioned, and they will say he or she is having low back pain. Why? Because what kind of X-ray findings will you notice? We will notice osteolytic lesions. Lytic breakdown is going to be there. And which bodies? Now that is exactly what you have asked me, but let me read the other questions also. Russell bodies and Dutcher bodies are seen in multiple myeloma. Where do you see Councilman bodies? Councilman bodies are seen with hepatitis C virus infection or some kind of viral hepatitis, and this is a form of apoptosis, ma'am, that we study in chapter 1. Where do you study Mallory hyaline bodies? Guys, what is the composition and kahan pe dekhne ko milta hai? It is composed of cytokeratin 8 and 18. It is seen in a lot of diseases. One of them is alcoholic liver disease. Yes, sir. Previous year questions on bodies. Russell and Dutcher are seen in multiple myeloma. I'll teach you. Councilman bodies, hepatitis C, very commonly it is apoptosis. And yeah, we are coming to New Indian Watch in a while, but Mallory hyaline bodies, most commonly alcoholic liver disease, made up of CK818. Very famous question. Chalo, in sab pe baad mein aayenge. What are these Russell Dutcher bodies? Same screenshot from the Q bank I have in front of you. We are having Russell and Dutcher. So, ma'am, both of them. Who was asking me earlier कि ma'am plasma cell कैसा दिखता है? Can you please tell us? Now I will show you how plasma cell. Focus on the normal. You just don't focus on these bodies. Just focus on plasma cell. This is a plasma cell. How I identified was that it has a nucleus which is on the side. I'm writing it for everyone who wants to know how a plasma cell looks like. What is the nucleus? मैम साइड पर होता है, eccentric. इस फोटो में ऐसे नहीं दिखेगा, but it will be written in the paper that what kind of a chromatin does it have? Very good. It has, everyone started mentioning, ma'am, it has cartwheel chromatin. Good, guys. It is going to, and they won't show you a picture of cartwheel chromatin. They are just going to tell you there is a cell with cartwheel chromatin. Now if you look carefully around the nucleus, thoda white area hai. Exactly, and that is going to be a perinuclear halo. Can anyone tell me the reason? I wasn't expecting ke normal padenge, but anyway, why is there a perinuclear halo? Because this has a lot of Golgi apparatus. Why has God given plasma cells so much of Golgi apparatus? Because ma'am, plasma cell has to make antibodies, immunoglobulins, IgG, IgA, etc. And immunoglobulins are proteins. So protein ka packaging, etc. के लिए what all do you need? You need Golgi apparatus. God has given a lot of Golgi apparatus. That is why the perinuclear area is going to be white. So three things. Nucleus is on the side. The nucleus looks like a cartwheel, and around the nucleus you see a perinuclear halo. Is this okay? Jisne, I forgot your name, sorry, but you had asked, students had asked me how does a normal plasma cell look like. I've told you. Now I'm coming to the cancer of the plasma cell, that is multiple myeloma. And number one, you see Russell and Dutcher bodies. So now when I zoom in, I want to erase this. You will notice that I can see there are bodies in the cytoplasm. So the ones in the cytoplasm are Russell, and the ones that are present in the nucleus are going to be Dutcher. So Russell are going to be cytoplasmic bodies and Dutcher are going to be nuclear bodies. What are they made up of? The most common antibody. They are made up of IgG. The most common antibody in multiple myeloma, IgG. Okay, now we come to the next one. Ma'am, if they are everywhere, they have started looking like a berry, a mulberry. So that is known as mulberry or mott cell. Pura cytoplasm mein bhar gaya. It is also made up of IgG. But when it starts looking like a flame, now see over here, it looks as if the cell is on fire. But that flame is also because of antibodies. But here the most common antibody is not going to be IgG. The most common is IgA. You guys have always learned it as jahan aag lagegi, wahan we will ma'am write IgA. So over here it is on fire, aag lagi, so I wrote IgA. For everything else, we wrote IgG. But you know, in the exam, what I have noticed nowadays, you are not getting questions on these. Ye photos na thoda old ho gaya hai. Means they know you have kind of gotten used to it. So they have started giving you photos of bone marrow biopsy in your grand tests and subject wise test also. You must be noticing students are not used to seeing this photo, but if you know how a normal plasma cell looks like, then this photo is also pretty simple for you. If I zoom into this, and obviously in the exam you won't have a zoom in option, so pehle I am zooming in, but exam mein aisa photo aayega. When I zoom into this, will you notice that pick up any cell of your choice. Let's start from here, let's go from here, let's go to these. Are the nuclei in the center or are they pushed out? Bas itna dekh lena. If you will see that the nuclei are all at the periphery, ma'am, nucleus site pe eccentric hai, they are all eccentric nuclei, and ma'am over here a little bit of halo is also noted, then that means yes, now see, you will get used to this because photo yahi aayega. Same photo will come, once you see it you will be able to pick it up in the exam. Let me zoom out. If it comes in this zoom out ability, again get used to it ki haan, there will be a photo of plasma cells which won't look like this Russell Dutcher, it will look like this bone marrow biopsy, and the nuclei will be at the periphery. This will again tell me about multiple myeloma. But what is the criteria? Plasma cell to dekh liya, I have to see antibodies. How do you see antibody? I will do SPEP. What is SPEP? It is serum protein electrophoresis. It is serum protein electrophoresis. Serum means what sample will I take from the patient? A blood sample I will take from the patient. So we all know that path, the way of learning proteins. Let me just teach you a normal, ye blue color wala photo dekh lena. Normal blood I am teaching you. What is the maximum protein that we have in our body, in our blood? The maximum which you learn with this little finger, and that is going to be albumin. Everyone in front of your respective screens, this is how you should be sitting right now. Irrespective of whether you're in a library, people around you think you've gone mad, but never mind, sit like this. This is what it looks like. This is an albumin spike, which is normal. Maximum is albumin. Then comes three chota proteins, three fingers of yours. So what are the three chota proteins? The alpha 1 protein, the alpha 2 protein, and the beta proteins. Okay, after these three fingers comes a chota sa mountain, a hump kind of a thing, a mountain kind of a thing, and that mountain is known as the gamma region. Gamma means it is immunoglobulins. So this is IgG, AMD, all the immunoglobulins. But now I'm talking about a case of multiple myeloma. The only difference, see, the same yellow color lining is everywhere, but now the IgG, I can't make my thumb longer than that, but the IgG has come out to be a spike. So now it's looking like this. Okay, a yo sign it has become. So please note, this is known as the M spike. Perfect. This is M spike. That doesn't mean it has IgM. M spike means myeloma spike, multiple myeloma spike. The antibody is still IgG. One question for INI-CET students and even for NEET PG, not important for FMGE. This just told you M spike. Now that could be IgG, that could be IgA, that could be IgM. This just told you IG, some IG. And you assumed that multiple myeloma hai, so it must be IgG. But how can you work on assumption in medicine? If you want to know the type of antibody, what is done? Immunofixation electrophoresis. Immunofixation also, if you learn, is good enough. Ma'am, by immunofixation, I will be able to know that IgG hai, IgA hai, IgM hai, or whatever. That is a question that came in the last INI-CET and NEET PG also. So this you have to know. Finally done with this, I think we are on our way to doing, okay, Dr. Gaikwad, you just gave the answer to the next question beforehand. Okay, ma'am, the same M spike is asked. I would think, acha, zyadatar to it is IgG. But now they changed the leukemia, they changed the lymphoma, they changed the disease, they've changed instead of multiple myeloma, they've given me Waldenstrom's macroglobulinemia. Macroglobulin is the biggest molecular weight immunoglobulin. Now what the answer is? Yes, in multiple myeloma, the most common was IgG, but in Waldenstrom's macroglobulinemia, macroglobulin, because it has the maximum molecular weight, it is IgM. So now please tell me, for INI-CET students, I have three questions. First one you have answered, IgM will increase. Second question that you will answer, what is Waldenstrom's macroglobulinemia also known as? It is known as LPL. Very good. It is leukemia or lymphoma. Lymphoplasmacytic lymphoma is the better word. Dr. Debicki, that is the better word. Okay, so lymphoplasmacytic Lymphoma is going to be the better word. Okay, clinically patient को क्या होगा? Ma'am, IgM बढ़ गया ना, but IgM has a lot of molecular weight. It makes your blood very, very thick and viscous. So this is going to result in hyperviscosity. This is going to result in hyperviscosity, those kind of thick blood symptoms. So you will have hypertension in the patient. There is going to be loss of vision that the patient will come to you with. So that is what you notice. But apart from that, they will ask you, क्या अच्छा lymphocyte दिखेगा? Yes. Plasma cell दिखेगा? Yes, of course. Lymphoplasmacytic lymphoma. What else will you see? You will end up seeing mast cells also. Okay, then they will ask you, what is the most common genetics? Genetics is usually deletion 6, and if it is not deletion chromosome 6, then it is mid 88 mutation that you get to see over here. So look at the MMM story that has happened. Waldenstrom's macroglobulinemia shows you IgM, lympho and plasma cells are fine, but apart from that it shows you mast cells, and the genetic mutation asked to me is going to be mid 88 mutation. So all of this is going to come up under Waldenstrom's macroglobulinemia. Dr. Monica, I think I've answered your question of how to learn the mid 88. Now, before I move forward, I think there is one question that I want to ask you. This multiple myeloma patient had low back pain. So whenever some elderly person, male or female, comes to you with low back pain, you will get an X-ray or some radiological investigation of the lumbosacral region to see slip disc to nahi ho gaya and all of that. So then you saw that there were osteolytic lesions, bone was breaking, then to you thought of multiple myeloma. But if it is osteoblastic lesions, especially if you are dealing with low back pain in a male patient, which is the cancer that you are going to rule out, it is going to be prostate cancer, because when it goes to the bone, the lower back, that is lumbosacral region, it causes osteoblastic metastasis. Very, very good. But now this is both elderly patients. I say osteolytic lesions in a child. Now a child is not going to have multiple myeloma. In children, think of Langerhans cell histiocytosis. Have you read this in dermatology? Langerhans cell histiocytosis, yes or no? Irrespective, Langerhans cell histiocytosis gets you two very classical questions. If they ask you the classical CD marker, it is CD1A, and if they ask you the gold standard investigation, that is going to be electron microscopy. Very good. Ma'am, we know that tennis racket appearance of which granules? It is going to be the tennis racket appearance of the Burbeck granules that you are going to see on Langerhans. I mean, you've done it in derma, I'm sure, but I'm just revising because these questions come. CD1A is going to be very important, and Burbeck granules showing you the tennis racket appearance. Lots of tennis rackets I have to teach you, but that will come when we go to microbiology, because many organisms show you that. Moving on to the next question, I think the last two for this, and then we can start with the general path also. What is the storage temperature and the shelf life of fresh frozen plasma? Only fresh frozen plasma has been asked. So obviously, if your common sense is working till now and you've not slept off, then it has to be something to do with frozen minus kana. And whenever you freeze something, it has to be going on for a longer time, that is 1 year. Common sense question. But when we see blood bank questions, we get scared. So what all of you are going to do, you're going to write all the blood products, their temperatures, their shelf life, and anticoagulants. So let's start. Anything that is red blood cell, whether it is packed red blood cell or whole blood, red blood cell is kept in the refrigerator, means a 2 to 6 degrees centigrade. Regular refrigerator similar to the one that you have in your house. Shelf life will depend on the anticoagulant that you have used. If you have used acid citrate dextrose, ACD, 3 alphabets, you can store it for 3 weeks. If you have used citrate phosphate dextrose, CPD, again 3 alphabets, 3 weeks, 21 days. To citrate phosphate dextrose, I am now adding add an adenine. Adenine क्यों add करा? Because with adenine, ma'am, we must be getting that ATP, ADP, energy मिलेगा, shelf life will increase. So C, P, D and A, I have counted 5 characters. So now it becomes 5 weeks, that is 35 days. But if I want to add citrate, phosphate and sagum full form also you don't know, let me just read it out, you will understand how much energy I am giving to the cells. Saline, adenine is ATP, ADP, glucose, mannitol. Can you see? Adenine, glucose, mannitol. The cells are getting so much of energy, 6 alphabets. Now the cells will survive for 6 weeks, that is 42 days. Obviously, CP sagum happens to be the best, but at the same time is very expensive. So what we use most commonly in our blood banks is going to be CPD and A. So we figured out something which is economical also and which is pretty good also. Okay with everyone, 3 alphabets wale ke 3 weeks, 5 ka 5, 6 ka 6. That is for red blood cells. What about platelet? Platelet rich plasma is always kept in a platelet agitator. Same photo they give you. These platelet plates are always going to rotate left right घूमते रहते हैं. Why? Because the platelet has to be kept in agitation. Why? Otherwise it will become clotted. You will leave it at one place, it will all start clotting. You don't want that. The temperature over here is 20 to 24 degrees and the shelf life is only 5 days. However, if the machine stops working, now the shelf life comes down to only 1 day. Power failure ho gaya, machine is not working, the platelets are not moving left right, they have come to a standstill. Now it is going to be just 1 day. You can't keep it beyond 1 day. Practically speaking, we don't even keep it beyond 2-3 hours. But textbook says you can keep it for 1 day and then you will discard. Now coming to fresh frozen plasma, obviously frozen means anything less than -18. Like in the previous question, -30 was written, so chalega. Anything less than -18, and you can freeze food for a very long time. So frozen blood can also be stored for 1 year. But if you melt, I mean patient ko jab dena hai, you can't put ice because it's frozen like an ice. You can't put ice into someone's body. You will get it to room temperature and then give it to the patient. So that melting is known as thawing. You don't say melting of blood, that is known as thawing of blood. Okay, that is known as thawing of blood. Ho gaya, melt ho gaya, but then your surgery got postponed for some reason. Now you can't freeze the blood again. Now the shelf life again comes down to 1 day. Either you use it within 1 day or then you'll have to throw it. So whenever anything fails, like machine nahi chala, freezer nahi chala, everything then comes down to 1 day. That is how I've learned it. That is going to be fresh frozen plasma. One question, fresh frozen plasma is plasma because what do you want? You want have, this will have all the clotting factors, the coagulation factors. From this, for INI NEET students, there can something be made called as cryoprecipitate. Cryoprecipitate also has factors. It is also given for the same clotting factors. But which factors does it have? Cryoprecipitate has the first factor, which is fibrinogen. Then it has the last factor, which is factor 13. Then it is also going to have the two people who are dependent on each other. That is factor 8 and von Willebrand factor, because factor 8 and von Willebrand factor are like brothers who always work together. So first factor, last factor, and the two brothers are for cryoprecipitate. So let's assume you have a patient of which hemophilia will you give cryoprecipitate to? Ma'am, hemophilia A is a deficiency of factor 8. So it is a deficiency of factor 8. So I would want to give cryoprecipitate. In a patient of von Willebrand disease, what can you give? Von Willebrand disease is a deficiency of von Willebrand factor. I can again give cryoprecipitate. Okay with everyone? Don't ask me cryo को कहाँ store करते हैं. Again, it is going to be that same less than -18 word only tells you. So no one will ask you this. Coming to the last point. Now coming to this question. What is the color of the vacutainer that contains sodium fluoride? Question 1. सबसे ज़्यादा questions twist turn इसी पर होते हैं. Hence I've got you this. Color of the vacutainer with sodium fluoride is going to be gray, ma'am, because this is the one that gives us that glucose estimation. G for gray and G for glucose, sugar testing. Next question. I've got you that gray color vacutainer. What is the anticoagulant in this vacutainer? So many times I've asked you, what is the anticoagulant used over here? Okay, many of you are saying C, and that is exactly what I wanted you to be very certain of. Our problem is we look at gray, we say acha gray matlab glucose, and glucose ke liye we must have added sodium fluoride. You're right. We have added sodium fluoride. That is an additive. But if I ask you the anticoagulant is going to be potassium oxalate. I asked you the anticoagulant. This will stop the clotting of the blood. An additive, that is sodium fluoride, that will go and inhibit an enzyme called enolase so that the glucose is not used out. I mean, you want to test glucose levels. Na? If the glucose only get used up, then what will you test? So you don't want glucose to be used up. To inhibit the glycolysis, you inhibit the enzyme enolase, and that is what sodium fluoride is going to do. So this is your basic, and now I'm going to show you the most deadly table. Don't get scared. I've tried to squeeze in everything in this one flashcard because this is definitely, irrespective of your exam, going to get you a question. And now you'll have to be patient for 2.5 minutes, and we have to do everything that comes this way. कोई confusion है ही नहीं, Dr. Ankit, last year वाला. वो I'll come to that. कोई confusion नहीं है, last year भी answer clear था, अभी भी answer clear है, but I'll come to it again. We have a sequence that is known as stop light red, red yellow green, green light go. इसका क्या मतलब? Whenever you have to put blood in the vacutainer, I have arranged them in the same order. You will say, okay, red light क्या था? Red, yellow, green. What does the red light say? Red light says stop. What does the green light say? It says go. So we will learn it as stop light red, red, yellow, green, and green light go. So let's start. Whenever you collect blood from a patient, you are first going to put it in a sterile microbiology culture, not in any of these colored things. First, the blood has just been taken out. Before you expose it to the environment and contaminate it, send it to the sterile, send it to microbiome lab. So, सबसे पहले sterile. After that, you put it in light blue. Light blue is going to be used for what? Anything to do with coagulation studies. Like right now in DIC, you were doing PT, APTT testing. All of those are put under light blue vacuoteners. And if you are doing ESR by Westergren method, please note, I will tell you 3 methods of ESR. Note all 3. First 2 are manual, that we are doing it as human beings ourselves. If we are using the Westergren pipette, then that means we are going to take the blood in the light blue. You will tell me what is the anticoagulant in light blue? It is, everything is 3. So it is 3.2% trisodium citrate, 3.2% trisodium citrate. Dr. Kuldeep, no, it's not a 5-hour class, but definitely a 3-hour class. 3 or 15 minutes. Okay. Now moving forward to the next one. We've got light. ये तो हो गया. Light के बाद red and yellow. Red and yellow come for the same thing. Because in red and yellow, you want that the blood should clot. I want that the blood should clot over here and the blood should clot over here. And what is left behind is the serum. Because I want that in the serum, I should do some tests. Like for example, serum urea, serum creatinine, so KFT, serum bilirubin, so LFT, all your hormones like serum prolactin, serum TSH, serum testosterone, all enzymes like G6PD deficiency anemia का diagnosis करना है, G6PD enzyme levels, red and yellow vacuotainer, all antibodies, COVID antibodies, HIV antibodies, hepatitis antibodies, red and yellow. Then what's the difference? In red, the clotting time is going to be 60 minutes, whereas in yellow, we reduced it to half to clotting time being 30 minutes. Because please note, in the yellow one, I added something extra, and that extra is going to be a gel. So because of that gel, the clotting time came down. Jaldi clot ban gaya. So just imagine now, you are an intern in the gynae ward. Do you think that you were given a sample at 7 o'clock and 8 o'clock tak if you tell them कि अच्छा अभी तो blood clot हो रहा है, then I will get the report. Imagine, will your internship completion certificate be signed then? I don't think so. So that means that a lot of people will be shouting on you. You need to collect the sample, be smart. Try to search for the yellow vacuotainer, because there the clotting time will be come down to 30 minutes. The pathologist will give you the report faster, and your internship completion certificate would also be signed. So now when red and yellow, for faster results, go for yellow. Okay, so red and yellow is going to be done. Now we come down to green. Green is hara. Hara has heparin. Okay, green is hara and hara has heparin. Usually, practically telling you, it is only used nowadays in anesthesia for arterial blood gas analysis. ABG analysis के लिए we use heparinized vials. Textbooks say that electrolytes are also best tested, and that is what someone was asking me, मैम वो green वाला confusion clear कर दो. कोई confusion नहीं है. Textbook में लिखा है electrolyte measurement is best done in heparin. MCQ आएगा तो electrolyte measurement is best done in heparin. Practically telling you, most of us don't have this in I also don't have this in my lab. So we don't have this easily accessible. This is mostly accessible when we are wanting to do ABG in ICUs and all. So then when you don't have a green color vacuotainer, then do it in serum red and yellow. Practically you will be doing it in red and yellow, but textbook question aayega, where do you do electrolyte testing? You do it in green, okay? So try to be very clear on this. Now we come to the next one. Coming to the bread and butter of a pathologist, that is purple vacuotainer. कुछ भी routine test कराना है. Complete blood count, peripheral smear, reticulocyte count, ESR by which method? By Wintrobe method. Everything goes over here, and which is the anticoagulant over here? It is EDTA. To be very precise, they will ask you, कौन सा EDTA? K2 EDTA. They will write Na2, lithium, etc. Be very certain. Dipotassium EDTA, K2 EDTA. So everything goes into this, but glucose wala sugar to we know na ma'am, glucose goes in gray, and we have done anticoagulant is potassium oxalate, additive is sodium fluoride. Now a question comes, if they say any testing of glucose, random blood sugar, fasting blood sugar, postprandial blood sugar, glucose challenge test, glucose tolerance test, glucose ka ABCD koi bhi test, everything goes in gray. But if they say glycated hemoglobin, HbA1c, in this the sugar is being tested with regard to hemoglobin, now that will come in the lavender wala vacutainer. Don't put that in gray wala glucose. So now everything for gray is important. Gray में दो चीजें हैं, anticoagulant भी है, additive भी है. First catching point over here. Second is all glucose are put in gray, but glycated hemoglobin is going to be put in lavender. This is very, very important. Repeating once again, stop light red, red, yellow, green, green light go. That is the order that you are going to put it in. So this is a question that I saw in the Q bank. The vacutainer tube that is shown in the given image below, and I can see there is a, obviously no one got this wrong, it's a red color vacutainer. So what are you going to use? I'm not using EDTA. Trisodium citrate would have been blue. I'm not even using heparin would have been hara. Sodium fluoride to bilkul hi gray mein chala gaya alag. This is going to be a clot activator because you want the clot to be formed over here, and that is the red one. Simple question. Can we move forward to the next question over here? We have a 42-year-old man who undergoes liver biopsy for evaluation of the grade and stage of hepatitis C. Seems to be a change. The biopsy reveals ballooned hepatocytes and moderate inflammation. The arrow shows one acidophilic body. If you want, I can zoom into it. Acidophilic matlab pink color. So pink color body, which of the following processes best accounts for this? तो क्या बनाया मैम? When I saw hepatitis C and I saw viral hepatitis, I got reminded that अभी you told us about the Councilman bodies, and in Councilman bodies of hepatitis C, I will think of apoptosis. Do we have apoptosis? Yes, we do. That is apoptosis. But what are the other options that we have? Okay, this is certain. But ये क्या लिखा है ऊपर? क्या चीज होता? What would have been the history over here that you would have given me the answer of this? Answer to all of you are right. Hepatitis C, Councilman body ये दिख रहा है मैम यहाँ पर, and that is apoptosis. Intermediate filaments are nothing but CK8 and 18. कहाँ पढ़ रहे थे? That was Mallory Hyaline bodies. If they would have given me a history of alcoholic liver disease, then I would have said, oh, Mallory Hyaline body होगा, CK818 होगा. CK818 is what? It is an intermediate filament. So before I go forward, this is something I should have done yesterday, but for a reason I've done it today because I want all bodies to be in one place. Mallory Hyaline bodies are known as Mallory Denk bodies. You've already told me made up of what? CK8 and 18. Now how do you learn it? You guys were writing this mnemonic. I saw that. New Indian Watch. बहुत लिखा था. Today I will teach you New Indian Watch, or you only teach me because anyway you are teaching me. So what is New Indian Watch? Non-alcoholic and alcoholic liver disease, दोनों में दिखेगा. Okay, Indian for obviously Indian childhood cirrhosis, name is telling me. W for Wilson disease, which is copper overload. Now the problem is, as soon as you guys write Wilson disease and copper overload, you think acha H must be iron overload and hemochromatosis, and that's where I want to catch you. Mallory Hyaline bodies is only seen in copper overload, that is Wilson disease. It is not seen in hemochromatosis. Please do not mess up over here. ऐसा नहीं है W से Wilson तो H से hemochromatosis. Every time it doesn't work like that. Apart from that, alpha-1 antitrypsin deficiency. Did I teach this a lot to you yesterday? Remember chota bacha lal and having infection, having a disease lal. You remember that story? Past positivity. Alpha-1 antitrypsin can also show you Mallory Hyaline Denk bodies. Coming to tumors, of course, everything is in the liver. So, ma'am, liver is going to be HCC. What else can happen in the liver? Cholestasis and hepatic or biliary diseases. The H is not for hemochromatosis. Before I move forward, and I have done so, in case I'll just complete this. Mallory Hyaline bodies कब होता मैम? तब अगर intermediate filaments तब mark करते. उसकी history के लिए they would have given me something like New Indian Watch. Most likely they give you alcoholic liver disease, then I think of Mallory Hyaline bodies and I would have marked intermediate filaments. Someone is asking me, light green, dark green अलग होता है? Yes, light green is basically the salt is different. काफी देर बाद ये question आया. But light green में, when you write light green, it is a lithium heparin, and when you write dark green, it is going to be sodium heparin, since you asked me. But both of them can be used for ABG analysis. It's just the kind of heparin. Lithium is going to be light green and sodium is going to be dark green. Okay. Now moving forward, guys, coming back, main the question apoptosis ka tha, because this is council man bodies. How can you finish a session, ma'am, without showing us this? It will be criminal on your behalf. So what am I trying to show you? It is DNA electrophoresis, and on DNA electrophoresis, the most घिसा-पिटा photo, option A will be of a normal person because the DNA is bilkul intact, जुड़ा हुआ, correct, nothing, no problem. In option B, I can see the step ladder pattern. Step ladder is the term that everyone uses on Telegram for PrepLadder so that you don't get banned on most of the groups. So step ladder is going to be seen where? It is going to be seen on apoptosis, necrosis, both, but most commonly it is seen on apoptosis. Okay, coming to next, the third pattern is what? The third one is known as the smearing pattern. The smearing pattern, again, this is another very common confusion. Imagine chapter 1 का भी doubt चल रहा है, तो मतलब we are wanting to read advanced things without clearing our concepts. Smearing pattern, we study is seen only in necrosis, but guys, studies show that this can be seen in apoptosis also. So my take home message for you that I want to give you is both patterns are seen in both cell deaths. Answer दोनों का दोनों, both का both. But most commonly step ladder is seen in apoptosis and smearing is seen in necrosis. I hope that is clear to everyone. Moving on to the next question, which is, let's see, first I want you to solve these two questions from the Q bank and maybe then I can start discussing. Question 1, I'll give you time to read. There is a 6-month-old infant who presents, I think it's zooming in and making it worse actually. There is a 6-month-old male infant who presents with recurrent bacterial infections including otitis media and pneumonia. Lab investigations show markedly reduced levels of all immunoglobulins, IgG, IgA, IgM. Flow cytometry shows complete absence of mature B cells in the peripheral blood. What is the most likely gene mutation? बिना fourth option के भी चलेगा. When what disease did you make, guys? अच्छा, I will ask you the diseases in a while. Answer तो ठीक है. एक और बता दो. Which of the following defect is most commonly seen in LAD1? ये तो ऐसे ही पता लग जाएगा. When we used to write LAD1, I always told you integrin. कौन सा integrin? It is beta 2 integrin that you are going to think of. Okay, nobody marked, someone marked CLL LUEX, that is going to be for LAD2. 2 का S बनाते हो तो CLL LUEX. So what I've done for all of you, this table I've not even hidden it because I want you to revise it with me. ऐसे eyes close करके podcast की तरह सुनो, because you have done it so many times and you have to revise it just once before the exam. So this is going to be give your eyes some relief. And you can actually, don't sleep off bus, give your eyes some relief, close your eyes for 10 for a minute and listen to me like a podcast and keep answering with me. I don't know if you would be doing this, but if you do, your eyes will actually get a lot of relief from the screen time. So we have two types of LAD. One is known as LAD1 and the other is LAD2. LAD stands for leukocyte adhesion defect. Actually, I'm not asking you anything. It is a podcast that I'm giving you for 2.5-3 minutes. So LAD1, the way you write 1 is the way you write I, integrin. LAD1 is a problem in beta 2 integrin, and LAD2, the way you write 2 ko flip kara, you get S. So LAD2 is going to be a problem in CLL LUEX. Now, defects are done, both of these, whether LAD1 or LAD2, patient comes to you with lots of infections, pneumonia, otitis media, diaper rash. Mother will say infection happening, but then how will you know LAD1 versus LAD2? In LAD1, there is a problem in the umbilical cord shedding. Mother will say 4 weeks after birth, umbilical cord did not shed off. That is LAD1. But the mother says, look at his blood report, he has Bombay blood group. That is going to be LAD2. Now, in case your eyes were closed, open your eyes. Because Bombay blood group pe last year FMGE exam mein बहुत अलग question आया था, which has not been asked before in any exam. If I have to give you your blood report and I have to say you are B positive, I will write B positive. Khatam. That's your blood group. But if I have to tell someone you are Bombay blood group, how do I write it? It is not written like this. It is written like capital O and small h. This phenotype will tell me Bombay blood group. So what is Bombay blood group? A person in whom all the antigens are missing. No A antigen, no B antigen, no H antigen. And all the antibodies are present. Anti-A, anti-B and anti-H. That person, all antigens absent, all antibodies present. That is Bombay blood group. How is it written? Which phenotype? It is OH phenotype. Last year का FMG का simple question था, one liner. मतलब question was framed in a very simple manner, but the answer wasn't. How do you write Bombay blood group? it is going to be the OH. Now let's move forward. So LAD1 के साथ umbilical cord problem, LAD2 के साथ Bombay blood group खत्म. Now Brutons, which you guys know, B for Brutons, B for most commonly seen in boys. It's a problem in the B cells. That is why the question over here said that there is complete absence of the mature B cells on flow cytometry that is seen. And it is a problem in the BTK gene, which you guys correctly marked it as BTK. But how did you know? It is Bruton's hypogammaglobulinemia, because hypogammaglobulinemia, you can see all the antibody levels are decreased, but most commonly IgG goes down, and we know IgG is the most important opsonin. So ma'am, if IgG is going down, the opsonization is going to become defective. Okay, moving forward is going to be the next one, Shediac-Higashi. Shediac-Higashi syndrome is a problem in the LIST gene. What do we mean by LIST? Some problem in the lysosomes. Lysosomes are not just present in one cell. Lysosomes are present everywhere in your body. So Shediac ka bacha, you can see, is having problems everywhere in the body because lysosomes are going to get affected. Okay, so now someone said this person can't donate to anyone. Yeah, I think you're talking about Bombay blood group. Yeah, Bombay blood group people can receive blood only from another Bombay blood group people, because you can see the kind of antigen antibody status they have in their body, right? This will not match with anyone else's blood group. So blood transfusion can happen between Bombay people only. Is that okay? Coming back, when I talk about Shediac-Higashi is LIST, lysosomal gene problem. So ma'am, we learnt it with Shediac's. Number one, brain mein problem hoga, neurological problem, CNS. But mothers in our country know only one CNS problem. My child is not getting marks in school. मेरे बच्चे के या तो marks नहीं आ रहे या milestones नहीं achieve हो रहे. बस these are the two things that mother knows. Then she will say there is a neurological problem. So you will have to derive in her language. If she comes and says that we have taken him out of school, he had to drop a class, he's not getting grades, you will start thinking of some kind of neurological problem. Then lysosomes in the blood start going problematic. The patient is going to have hemorrhage, lot of bleeding problem, platelets kharab ho rahe. Then next is going to be decreased immunity. Of course ma'am, lysosome not working, how will phagolysosome form, how will phagocytosis occur? तो infections होगा, immunity down हो गया. Next, the skin starts having a problem, albinism. Look at the child's hair, classical photo. He will come walking into your OPD, you will see, oh, look at his hair, look at his eyebrows, look at his eyelashes. He has silvery grey hair, albinism का issue है, pigmentation का issue है. Then इतना पढ़ा तो give my pathology also little importance. K for coarse cytoplasmic granules. Coarse cytoplasmic granules means any cell that they will give you, whether it is this cell over here, these are usually neutrophils, they will show you that there are some big granules that I have. These big granules are the coarse granules. So now usually what they do is 2 questions. Everything is written. First question that they ask you is pathology mein kya hoga? Coarse granules. Second question they ask you is what is the genetic defect? Lysosomal LIST gene problem. Coming to the last one, and then I take up all your questions and I come back to the questions as well. That is CGD, chronic granulomatous disease, is going to be a condition in which there is going to be NADPH oxidase defect. NADPH oxidase kiska enzyme tha guys? It is an enzyme for phagocytosis. And if they ask you what is the gene defective, NADPH oxidase is going to be a defect in the FOX gene. How will I pick up clinically that these patients are going to be having CGD? Catalase positive infections. I'm not giving you any homework today. What, I will be meeting you again on Monday, na? That is for micro. So the homework for Monday is catalase positive organisms ki list. वैसे भी रटना ही है. You have to study and come for micro. So you will study all the catalase positive organisms ka list and come, like Staph aureus and Candida, etc. That you will study. All of those infections are seen in chronic granulomatous disease. What is the screening test and what is the diagnostic test? The screening test is going to be NBT. NBT, I think you all know the full form, nitro blue tetrazolium test. And the diagnostic test is going to be the DHR test. There are 2 ways of learning it. Ek to ho gaya, you can learn diagnosis wala test is going to be DHR, and next way of learning is screening, chota wala test. All of you, many of you have started writing nibba-nibbi. Yeah, so NBT sounds, although it is nitro blue tetrazolium, we used to learn it as nibba-nibbi testing. Nibba-nibbis are the small teenage couples that keep posting all cringe cheesy videos on social media. So chota babies wala test is going to be screening wala NBT, nibba-nibbi test, but actually is nitro blue tetrazolium test. And diagnostic wala is going to be the DHR test. So much I spoke. Why don't you speak alongside with me? If I say LAD1, so now you know which is the problem. It is a problem in I for integrin. Someone marked LAD2, I would have said it is going to be CLL-Lewis defect. Coming to the first question, hypogammaglobulinemia, because of B for Bruton, B for B cells, that is why B for BTK gene defect. The questions are not over. You are going to mark the questions for me over here as well. There is a 4-year-old boy who's got to the physician because of a large painful boil on his left knee. He has a history of infections with Candida, Staph, Klebsiella since the age of 14 months. Lab tests show abnormal nitroblue tetrazolium testing. I think I made my answer. ये देखो ये सारे catalase positive organisms थे. Plus ma'am, the NBT testing has been positive. This is a case of chronic granulomatous disease, which is a deficiency in which enzyme? How simple? NADPH oxidase. They might have written it as Fox gene. It means the same. Now let me go on to another question. Now is your time, guys. There is a 19-month-old male who presents with recurrent infections. Peripheral smear shows neutrophilic leukocytosis and advanced studies show a defect in neutrophilic adhesion. Mother gives history of a delayed umbilical cord stump shedding. That is classical what? LAD1. LAD1 किसका problem था मैम? LAD1 was a problem in integrin, beta-2 integrin, and integrins are responsible for what? Adhesion. So see, examiner has written problem in neutrophilic adhesion is seen. One more question I think we have on this. There is a 10-year-old male patient who presents with history of recurrent infections, easy bruising, light sensitivity. There is fair skin, light hair and nystagmus. Fair skin, light hair. Are they talking about silvery gray hair? Maybe albinism. Prolonged bleeding time and large coarse cytoplasmic granules with List gene, classical Shediac-Higashi syndrome. मतलब मैम List gene का problem हुआ, lysosome का problem हुआ. This is phagolysosome. Did you notice we had learned Shediac-Higashi as Shediac? So is there anything to do with some neurological involvement? Maybe the nystagmus is pointing towards the neurological association. Then easy bruisability. So there is hemorrhage, decreased immunity. There are a lot of infections, albinism because he has fair skin with light hair, and coarse granules which are mentioned over here. It's about how you pick it up from the question. The mnemonic will be written as it is. Language, of course, you have to do 2 plus 2 in the exam. Okay. Now I move forward and ask you this. This is only for INI-CET students, okay? There is a 35-year-old male with a known history of selective IgA deficiency. So I'm sorry, the font is a little small for this question because it's lengthy. Selective IgA deficiency is going to be there. And he wants to receive a blood transfusion during a surgery. Shortly after the transfusion, he develops a lot of allergic reactions like hives, difficulty in breathing. So given his IgA deficiency, which blood product should have been considered so that he wouldn't have had all these problems? Everyone has learned washed RBCs. ये ना कहीं for INI-CET students, even for NEET it's important, not very important for FMG this question. So what they say, when someone has IgA deficiency, by birth that person has IgA deficiency. When by birth you have a deficiency, it means you have never ever seen that antibody. You've never seen IgA. For you, IgA is not a normal occurrence then. For you, IgA becomes a foreign element. If you ever encounter IgA, then you will think, this is something like a bacteria virus. I have never seen it. And then you will start showing responses to it. Now, when this person got a blood transfusion from any normal donor, then that normal donor to had IgA. Instead, I'm saying I'm putting IgA into this person. Of course, he will show a lot of reactions. So I will give washed RBCs. Washed RBCs means that RBCs which are basically washed with normal saline. Why are you washing them with normal saline? Because you want to remove all the antibodies. You want to remove all the immunoglobulins, remove all the IgA. That person should not receive any IgA and he should not show any kind of reaction. Is that okay with everyone? Yes, all good. Any confusion up till now? Because I am now moving forward to the next question. Last option not visible. Sorry, that was fresh frozen plasma. That you will not at all give, because plasma will to have lots and lots of antibodies, and that is going to create an entire havoc in this patient. So you will not, and you will never give products which are rich in IgA. That is also not making sense. You will not give standard red blood cells because you were giving those and patients ended up having reaction. You will give washed RBCs. Is this okay? Someone has been asking me again and again, यही वाला session देखना है. Previous session you can see, I mean I'm not stopping you, but I have incorporated every question over here, made it 1 hour lengthier than the previous one so that you have new, old, everything in one place, and you are not viewing 3 LRRs in the name of LRR. You have not made another RR out of your textbook. That is why these sessions are, 1 hour extra than the previous sessions, because इसमें सब कुछ include करके डाला ना. Okay, now moving forward to the next one. What is this? A 25-year-old male comes to the clinic with concerns about his physical appearance and fertility. Male patient. On examination, there is a tall stature, long limbs, gynecomastia in a male. I will always think of one syndrome which I think is Klinefelter, which everyone has thought of. Reduced body hair also. Struggled with learning, which means there is mental retardation. Image diya hai ma'am, XXY. This is 47 XXY, which basically means that it is a case of Klinefelter. Actually, chromosomal disorders, pray to God that you get the maximum questions. Reason being that they are the easiest. I mean, who can not? I have numbered it. Examiner will not number these also at times, but be rest assured it will always be arranged like this. So gin lena. 1, 2, 3, 4, 5 chromosome ऐसे ही arranged होगा. So what technique is it? Tell me all karyotyping questions. Ma'am, this is a karyotype technique. If you wanted to do arrest in a karyotype, you are going to arrest it in metaphase. I hope you've not forgotten that in fish, I was arresting the cells in interphase. In karyotyping, I am arresting the cells in metaphase. By which chemical? I am doing it by colchicine, right? I am doing it by colchicine. Next, I will ask you what is the fixative. So, carnoy fixative, carne fixative, carne fixative. Sorry for being so mean, but that is how examiner goes ahead with it. It is carnoy fixative. Please note over here that yesterday I taught you something called Carne's complex. Somewhere in the heart, do you remember a tumor called myxoma of the heart? Over there I taught you that Carne's complex is in myxoma of the heart. Yes, वो अलग. This is carnoic. So car for car and yo for yo. So be very yo-yo in the exam. Okay, carnoic fixative for karyotyping. Please don't mess up. Now coming to that. Okay, I can see two stains over here. One is known as the ऐसा simple सा ऐसा मैम black and whitish type लग रहा है. So that is the G banding. G stands for GIMSA, and for GIMSA I use the regular light microscope. The second one is looking a little fancy because I have used the fluorescent microscope, and for fluorescent microscope I need a fancy wala stain, that is the quinacridine stain. That is why it's looking so fluorescent. How did we learn it? That for the queen you will need something fancy, and for Garib, Jimsa Garib, so you will use Garib wala microscope, light wala usual. For Jimsa we use the usual microscope, for the queen we use the fluorescent microscope, but of course ma'am we always want to save money. Most commonly we use G banding in our labs. Why do we call it banding? Because the chromosomes are dekho, dark light, the chromosomes are looking like bands. They are not all one color. The chromosomes are looking like bands. Now I move forward. Now the diagnosis is so simple ना, ये तो मैंने पूछने के लिए भी नहीं रखा. ऐसे एक बार देख लो for revision. Trisomy 21, 321 दिखेंगे तो what will you call it? Down syndrome. If you will see 313 chromosomes, you will call it Pettau syndrome. If you will see 318 chromosomes, what will you call it? You will call it Edwards syndrome. Yesterday in Edwards syndrome, you studied one strawberry, if you remember. What will the radiologist tell you? The radiologist will tell you something to do with strawberry skull. This we had studied yesterday. Is that okay with everyone? Yes. Now we move forward and come to a question which I'm sorry for asking you, but what choice do I have? Because you will get a question, you will cry in the exam, so it's better you cry right now. Identify the inheritance that has been shown in the pedigree chart below. Autosomal dominant, recessive, XLR, XLD. We've come to that part where 5 minutes of your life are going to go in knowing the rules of pedigree analysis. Yes, guys. D, all of you are saying XLD. I'm just taking your test right now. Okay, let's see question number 2. I don't know you're giving me right answers or not. Identify the inheritance shown in the pedigree below. Then I'll start teaching you. First is like a 2-3 minute test for all of you. Okay, perfect. So, ma'am, over here also again you want to say XLD. Okay, again, some of you are saying AD also. ठीक है, देख लेते हैं. Asking you the next question. Tell me the inheritance that has been shown in the pedigree chart below. You are giving me a quick 4-question test. Like how you should be doing it in your self-study also. Guys, as you complete it, then I'll give you one very good advice also. Most of you are saying AD over here, okay. And the last one, which I've got from the Q Bank, quick ABCD. These are the 4 options. Jaldi se. There's a community where consanguineous marriages are prevalent. These are the ones that happen between relatives, cousins. Relatives wala marriages are consanguineous marriages. So what is anticipated? What kind of pedigree is telling me consanguineous marriage? Okay, all of you have started saying B. mostly. ठीक है, so now what I want to ask you is, first let us start with the symbols, then I'll come to the pedigree. Symbols jaldi in 1 minute we have to do. Okay, let me start. I think you already know, if I draw a circle, that is going to represent a female, and if we draw a square, that is going to represent a male. But these days, more than that, they are more interested in asking you this diamond, because that indicates gender unknown. So I'm making some highlighting somewhere, because that is what you'll revise on the last day. अगर मैंने पूरा मेल फीमेल ऐसे ऐसे शेड कर दिया, तो मैम वी नो दैट इज गोइंग टू बी अ डिजीज. अगर आपने मैम मेल फीमेल हाफ शेड करा, मतलब दैट इज गोइंग टू बी हाफ डिजीज, विच मीन्स व्हाट, इट इज गोइंग टू बी अ कैरियर. इफ आई पुट अ डॉट इनसाइड इट, इट इज पर्टिकुलरली एन एक्स लिंक्ड कैरियर. बट डू यू नो, ओनली फीमेल्स कैन बी एक्स लिंक्ड कैरियर्स, males cannot be x linked carriers, so I have only made a female over here. Then after that, if I strike off the male and female, strike off matlab gone, dead, khatam, so that is going to be death. But if I only point towards them, means they are the person that I'm studying. He or she is the person who has come in my OPD. He or she is my index case. From this person, I have made the family tree and the pedigree chart. Is that okay? Next, थोड़ा सा वेट कर लो, आ जाएगा ट्विंस भी. मे बी देर आर 2 slides, give me some time. Coming to the next, now we come to, if male and female have a single line, that means marriage. If male and female have a break in that single line, this means divorce. The marriage is broken, so it is some kind of separation that they are telling. If male and female have 2 lines, that doesn't mean 2 marriages. Please don't get confused. 1 line means 1 marriage. 2 lines means consanguineous marriage, which means that marriage has occurred amongst relatives, and that makes a person, or not the people, I mean the people are not going to have a problem, but their future generation is going to increase the risk of autosomal recessive type of disorders in the kids. And that is the first question that we had put up over here. In a community where consanguineous marriages are prevalent, I think all of you could understand that 2 line wala symbol uthana tha. Now you can see the child is going to have features of anemia, requires blood transfusion. Further investigation shows that the child has had beta thalassemia. Beta thalassemia is an autosomal recessive disorder. So consanguineous marriages make the child at a risk of autosomal recessive. What could have been the cause? I just taught you. What probably would have happened is that this female was also a beta thalassemia trait, and this was also a beta thalassemia trait, plus they were of the same family and they got married. So there is a child who's now born with beta thalassemia major, and because he's major, he is requiring blood transfusion every bi-monthly or every month, whichever is the condition of this patient. So that is what can happen with consanguineous marriages. Coming back, someone was asking me about kids and twins. If you have a square bracket, that will tell you kids. First this kid was born, then this kid was born, okay. But if you have a common bracket, that is going to mean twins. Now twins are of 2 types, do alag alag zygote. So then do alag alag zygote means do alag alag genders. Maybe one of the twin is a female and one of the twin is a male, because they have come from 2 zygotes, okay. But if they have come from the same zygote, then their gender has to be the same, and the same zygote will tell me that I'm going to join them in the center. So if they are joined, this means they've come from a single zygote, monozygotic. If they are not joined, they are dizygotic. If I make a dash dash dash, means no kids. Now no kids could be by choice, no kids could be infertility, couples personal choice. And if I make a kid, whether it is a round or whether it is a square, and the 2 brackets are going to adopt it, that is known as adoption. This square, now this is another thing I'm highlighting. 2 things I feel wo jo kabhi nahi puche gaye. One is this gender unknown, I feel has not been asked, and one is this adoption that has not been asked, which could be asked in the INI-CET exam. Now coming back, this is over. Now I come to my simple basics of how will I go ahead with pedigree analysis. These are the 6 pedigrees that you get in the exam. Be very clear, you have to follow the 2G rule har pedigree mein. Now I'm going to make you solve even more. Guys, please hang on to all miscellaneous queries. I can't keep coming back to vacutainers after every 2 minutes. So what I'll do, I'll give you time in the end. Just let's finish off whatever is planned. Okay, I will not run after that. I'm there. I will take care of all your doubts. So coming back, what do we have? There are 2 G's. That is going to be gender and generation. Sabse pehle you will notice if there is any gender bias. Okay, gender bias will always tell me कि अगर तो नहीं है, means you are dealing with what? You are dealing with autosomal kind of disorders. If the gender bias is present, then it is X or Y linked disorders. So let me start. When I am thinking of autosomal dominant and autosomal recessive, will there be any gender bias? No, ma'am. The disease will occur in males also, females also, gender unknown, सब में disease होगा because it is autosomal. After I am done with this, I go on to the generation. Dominant tells me that dominating, it will dominate in every generation. All generations will be affected. Recessive means chupna, hiding. It will hide in some generations, it will show up in some generations, then hide, then show up. This means generations are going to be skipped. So simple, if there is no gender bias, I will then see the generation. All generations affected, dominant hoga, generations are skipped, तो recessive hoga. Now let's go on to gender bias hai, X and Y ka problem hai. Now in the gender bias, look at these two. I'm telling you quick ways of solving. If usually males are diseased and females are carrier, I'm saying usually males, which means let's assume a family has 10 male members. Dadas, chachas, kids, grandsons, everyone I have included. There are 10 male members. Out of 10, I am saying 4 have the disease. That could be a case of XLR. But if I'm saying 10 out of 10 are having the disease because Y chromosome goes to each and every male member, then that would be Y-linked. So just don't look at man, and answer. If some of the men are having the disease, XLR. If all the men are having the disease, that is going to be Y-linked. Whereas if the disease goes as a cross inheritance, means from the dad, it is going to the daughter. And when this daughter is becoming a mother, when let's assume she becomes a mother, it is again going back to the boys. Means from the dad it is going to the daughters, and from the daughters aage it can go to the boys also and the daughters also. So I'll tell you a way of learning. XLD. XLD tells you that from the dad it is going to all the daughters. Isn't it common sense? A dad is what? A dad is XY chromosome. So the X chromosome to will go to all the daughters, so XLD will go to all the daughters. And if there's a problem in Y chromosome of the dad, it will go to all the sons. That is pretty obvious. That is why, guys, I asked you the first question over here where you had a dad and the disease was only and only going to the daughters. Ma'am, dad was only giving the disease to daughters. This had to be XLD, DDD, dad, disease, daughters, XLD. Now in the next one, why you got confused, some of you, because you looked at the first generation and that's it. You said, oh, mother is giving it to the son, all genders are affected, but you didn't see. See, mother can give it to anyone. But when this boy became a dad, the dad has once again given the disease only to the daughters. I am again talking about XLD only. Dad giving the disease to the daughters is XLD. Moving on to the next. When in doubt, you go for 2G rule. So ma'am, the first G tells me gender. Is there a gender bias? Male has the disease, male has the disease, female has the disease, female, male, male. Sab mein disease ho raha hai. There is no gender bias. This is autosomal. Now generation. First generation has the disease, second generation has the disease, third generation has the disease, all generations have the disease, autosomal dominant. Okay, let me tell you some more examples. I've got you all of these. Tell me, pehla wala kya hai? Ma'am, gender, male, male, female, female, सब में disease हो रहा है. Any gender bias? No. So this is autosomal. First generation affected, second generation affected, third generation affected. All generations affected. क्या disease बना? Autosomal dominant. Okay. Coming to the next. Okay. This is what? This is gender. Ma'am, gender में female है. यहाँ भी female है. And then there is a male. So male, female both. Is there any gender bias? No. This means it is autosomal. Now let's come to generation. First generation affected, second, third skipped. Then once again fourth is affected. So generations are being skipped, and now what does this become? It becomes autosomal recessive. Coming to the next one. Start with gender. I can see male, male. See how many male members? 1, 2, 3, 4, 5. Are all of them affected? No. Some of them are affected. What do you want to call it? That is XLR. Males are diseased, and can you see females are carriers? This is XLR. Coming to the next one. When the dad is giving the disease only to the daughters, what do you want to call it? That is going to be XLD. Next, look at this. 1, 2, 3, 4. There are 4 male members in this family. All 4 of them are affected. Ma'am, all male members are affected. That is going to be Y-linked. Now, mosaicism is something that they will give you, but that will never be mixed. I mean, that will be mixed in a pedigree. For example, if they are giving, let's assume this, they will give another family along with it. Because of it, some kind of mixing will be there, but primarily you will be asked to identify which primary inheritance is going on. They will not tell you to identify mosaicism. Very good. Many of you said, ma'am, Y-linked को आजकल Y-linked नहीं बोलते. It is also referred to as Hollandric inheritance. So I hope now on the last day, what are you doing? And the pedigree that I have not shown you, which I believe सब लोग easily identify कर लेते हैं, that is mother to all, father to none. So I think mitochondrial inheritance is something which is very obvious and I have not spent time on that. But the last day, these are the 5-6 things that you're going to go and read and go. And in the exam, if you get stuck, see, there will be some questions where you will save time. Owl eye appearance 10 seconds में हो जाएगा ना solve. So if you save 30 seconds from such questions, then you can spend 30 seconds on pedigree extra. Which means that when you get a question and everywhere I tell you gut feeling पहला answer ठीक answer. Pedigree में ना when you get an answer in 5 seconds, usually you have done something which is an error. Only for pedigree I say overthink. Do overthink, think as much as you can. For other questions I say don't overthink. Gut feeling is the answer. For pedigree I say if you get an answer in 5 seconds, you have done something wrong. That is what I've seen with the students over the years. So in pedigree, if you're very certain, you think, oh, this is I think a case of autosomal dominant. Still you have 6 na, start applying them. कि कहीं ऑल बॉयज़ तो नहीं है, नहीं चलो वाई लिंक्ड तो नहीं है, कहीं डैड टू ऑल डॉटर्स तो नहीं था जो आई मिस्ड आउट, ओ है, देन दिस मीन्स इट इज़ अ केस ऑफ XLD. डॉक्टर शब्दीप, नॉन मेंडेलियन के पेडिग्री नहीं होते ना, मेंडेलियन के पेडिग्री होते हैं, हेंस वी हैव डन द मेंडेलियन डिसऑर्डर्स. ओके, वी आर स्टिल नॉट डन. आई हैव 2 more questions. आई न्यू दिस विल बी प्रॉब्लमैटिक, सो आई हैव गॉट यू more questions. कैन यू टेल मी व्हाट इज द इनहेरिटेंस ऑफ दिस विदाउट एनी ऑप्शंस? यू नो द ऑप्शंस. व्हाट इज दिस गाइज? क्या लग रहा है यहाँ पे? Yes. Okay, many of you said AD. AD you thought because you said, ma'am, I went by the rule. I told you na, jab answer 5 seconds mein hai to rethink. Here you have to overthink. So when you say that I have thought of AD, you said फीमेल में हुआ, फीमेल में हुआ, मेल में हुआ, फीमेल में हुआ, फीमेल में हुआ. So ma'am, it is no gender bias, so autosomal. And you then assumed all generations affected, so autosomal dominant. But then did you forget that from the mother it has gone to 50% of the kids, but when this boy became a dad, dad has given the disease only to the daughters. Do you want to rethink your option? See, this is the most common error, hence I got you one more time. You think it looks like an AD, but when the dad has given the disease to the daughters, you will think of XLD. Hence I said, when you get an answer in 5 seconds, rethink, go through those 6 sentences again, apply them, and you might want to change your answer. Okay, coming to the next one. First, yes, this is what we have. And there is a couple who seeks medical advice after their daughter presents with frequent nosebleeds and easy bruising. Lab investigations reveal prolonged bleeding time, prolonged APTT, and a normal PT. Detailed history of the pedigree analysis has been shown. Based on this, what is the likely inheritance pattern? Okay, yes. Ma'am, over here, what we noticed, there is, yes, there is a male having the disease. Male is giving the disease to both the kids. Okay. Then in the next generation also, it is going to a female. Inheritance क्या बना है? Many of you are saying AD, but then many of you are saying hemophilia, but hemophilia तो AD नहीं होता. Disease कैसे और inheritance कैसे? कुछ correlation ही नहीं बैठ रहा. Because this is not a case of hemophilia. Now I want to tell you that if you were thinking of hemophilia, whether it is hemophilia A or B, hemophilia A is factor 8 deficiency, hemophilia B is factor 9 deficiency, only APTT is increased in hemophilia A and B. Over here, APTT is increased, but bleeding time is also increased. Hemophilia does not show you bleeding time increase. So this is not a case of hemophilia at all. Yes, you are right, guys. This is a case of von Willebrand disease, because firstly and most commonly, von Willebrand disease is autosomal dominant, because over here, what did you see? Males में भी हो रहा है, females में भी हो रहा है. No gender bias, and all generations are getting affected. So this is AD. Now von Willebrand disease is a problem in von Willebrand factor. When von Willebrand factor is missing, the platelets cannot work properly, and factor 8 can also not work properly. There are 2 people who can't work properly. Platelet काम नहीं करेगा तो what is going to increase? Bleeding time will increase. Factor 8 will not work, so what will increase? APTT will increase, and this is the entire thing that was mentioned. BT increased because platelet not working, APTT increased because factor 8 not working and autosomal dominant inheritance. This was a case of von Willebrand disease. Yes, I mentioned it. I knew this question was coming. But ma'am, एक von Willebrand disease तो is autosomal recessive also. But then you, just because you have the knowledge doesn't mean कि जबरदस्ती question में डाल के आना ना. They have given you an inheritance pedigree in front of you. That pedigree chart is shouting in front of you that I am an autosomal dominant pedigree. I am also telling you again and again that the most common inheritance in von Willebrand is autosomal dominant. That doesn't mean it is not autosomal recessive. See, there will be variations. For example, hereditary spherocytosis, I told you, is autosomal dominant but can be AR. VWD is mostly autosomal dominant but can be AR, but that doesn't mean you will zabardasti make it AR. The question over here is on AD, autosomal dominant. Then if it would have been AR, they would have given me the flow chart of AR. Then I would have still marked von Willebrand disease because the history is going in favor of von Willebrand disease. Okay with everyone? Now coming to the next. Some of you said, but ma'am, hemophilia C is autosomal recessive. You guys are not trying to correlate these two things together. एक pedigree chart आपको दिया है. Hemophilia C is which factor deficiency? It is factor 11 deficiency. Over there also, only APTT is increased. Bleeding time is not increased. So how can you make it hemophilia C? And hemophilia C is autosomal recessive. This is the pedigree chart of autosomal dominant. Now वो pedigree में fit हो रहा है ना history में fit हो रहा है. That's what I'm saying. What you've done for hemat is अपनी diseases याद कर ली and then you keep forcing those diseases as your answers. No, it has to be the other way around. You have to see the patient and then come to a diagnosis, not make a diagnosis and then force it onto the patient, right? This is not something that you have to do in practice also. Moving on to the next question, which is, yeah, this is a little on the tougher side for FMG students, but for NEET and INI, this is a very important PYQ. And someone was asking me where are non-Mendelian disorders questions. So here they are. There is a 15-year-old male patient who presents with a typical facial profile of long ears, large mandible and long face, large mandible. So there's a long face, a large mandible, and there are large ears. Now there's a history of dropping out of school due to poor grades, which means there's mental retardation. Genetic testing is advised on the basis because this disease is also in a distant cousin, so it is a genetic disorder. There is a problem in chromosome X, which they have shown over here, and when they are grown in a folate deficient medium, you saw this. It looks as if chromosome X is breaking off. Fragile X syndrome maybe. For Fragile X syndrome, what will you do? Perfect. All of you are saying that this is amplicon length analysis. Okay, agreed. So I want to ask you a few questions of Fragile X syndrome, and along with that I will make you solve this entire question side by side. When I'm talking about any kind of Fragile X syndrome, the repeats that you are talking about is going to be the CGG repeats, and obviously we are talking about Fragile X to chromosome X. CGG repeats in you and me can happen up till 55 times. CGG 55 times, not a problem. That person is going to be completely normal. So 55, fit and fine. That's how we learn it. But when it crosses 55 to 200, then these CGG repeats result in a gain of function mutation. So ma'am, what is gaining? Whose function is gaining? Where are these CGG repeats happening? This is seen in the FMR gene. FMR, mental retardation. Today, if you're sitting over here with a normal IQ, thank FMR gene. FMR gene is working, so we are sitting here normally. In these people, FMR gene has been totally gone because CGG repeats have messed it up. FMR gene is totally gone. Hence, these people have mental retardation. So what happens when the CGG repeats cross 55? Then the gene starts working more. It becomes very excited. Oh, CGG are so much in number. Then the patient gets tremors and ataxia, not Fragile X syndrome. When does Fragile X syndrome occur? When the CGG repeats are going to cross 200. That is when Fragile X syndrome will occur, and that means now the chromosome has lost all the excitement, the gene has lost excitement, and it has undergone loss of function. I'll repeat it. Please note, till 55 CGG repeats, 55 fit and fine. 55 to 200 means the gene has started working more, patient has started having tremors and ataxias, and when this crosses 200, that is when the gene has stopped working, and that is Fragile X syndrome. Can I say 55 to 200 is a chota mutation called a pre-mutation, and after 200 is a proper mutation, bada mutation called mutation. So if I read this forward, can I say that what is incorrect about Fragile X syndrome? So it shows CGG pre-mutation. Is this correct or incorrect? Because CGG to theek hai, but does Fragile X syndrome show CGG pre-mutation? No. It shows CGG proper wala mutation, more than 200 wala mutation. Is it associated with loss of function of the FMR gene? Yes, ma'am, that is correct. Can they be detected using PCR? That is the question that I asked you. Yes, they can. Which kind of polymerase chain reaction is used? Amplicon length analysis. सोचो ना, lengthy DNA, CGG, more than 200 times. This is going to make the DNA very, very lengthy. For lengthy DNA, which is the PCR that we use? Amplicon length analysis type of PCR is what we are going to use. So coming back, if I ask you some more questions and I first finish that MCQ for all of you. So now tell me that Fragile X syndrome, I gave you one homework yesterday. I'm back to that. Is it XLR? Is it XLD or can it be both? Ma'am, Fragile X syndrome में कुछ भी हो सकता है, X में कुछ भी, but more commonly it is going to be XLR. And XLR diseases, ma'am, you've been telling us, are more commonly seen in men. So these diseases are most commonly seen in men. The question they ask you कि men में तो चलो है, but then what is seen in females? Female carriers can show you what, and that's an update. Female carriers can show you premature ovarian failure before the age of 40. Premature ovarian failure can be seen. So ye bhi, all these are correct. The incorrect statement was it doesn't show pre-mutation, it shows the proper वाला mutation. I'm happy all of you did the homework and came. And Fragile X का सब पढ़ा तो मुझे ये भी बता ही दो. Fragile X का all of you are saying कि मैम long face होगा. There is going to be a large mandible. There are large ears. Was this written in the question? Yes. The child was dropping out of school. Why? Because the child had mental retardation. Previous year NEET PG and INI question is what is the IQ of a patient of Fragile X syndrome? It is 20 to 60. Exact IQ was asked. वो भी पढ़ लिया. Facial profile भी पढ़ लिया. But what is the most characteristic? That is going to be macroorchidism, ma'am, large testicular size. Most characteristic feature asked is large testicular size. How do you do the diagnosis? You just now told me polymerase chain reaction का वो lengthy वाला amplicon length analysis. But if polymerase chain reaction fails, then which blotting is done? Southern blotting is done. I think that everyone has anyway told me, so I'm just telling you repeat points. Now coming back, इस वाले में amplicon length analysis तो हो गया. When do you do Sanger sequencing? Sanger sequencing is, and for students, FMG students, if you've not read it in Path, you will read this in Biochem also. So this is anyway important for you, कहीं भी पढ़ लो. It is the gold standard PCR that you have is Sanger sequencing. Southern blotting हमने पढ़ लिया. Pyrosequencing. Pyrosequencing is a type of PCR which you do for contaminated samples. What do I mean by contaminated samples? Contaminated sample का ये मतलब नहीं है that like let's assume there's a female with breast cancer. You've taken her breast cancer का biopsy. Contamination doesn't mean that the breast cancer biopsy is contaminated with some bacteria virus. Contaminated means that the tumor cells are very low. There is a low tumor yield. Instead of tumor cells, you've got normal fat, normal ducts of the breast, normal tissue of the breast, but you wanted tumor, cancer part. So when the cancer part is very low, that is the kind of sample you call as contaminated sample, which you test using pyrosequencing. Is that okay with everyone? Now the only question left is कि ये सारा तो हमने Fragile X syndrome and और पढ़ लिया, PCR पढ़ लिया, basic PCR जो biochem में पूछते हैं वो तो पढ़ा ही नहीं. What is the basic step, which is a previous year question of INI-CET again, 23 में पूछा गया था, November I think, and that is what are the 3 steps that you have? We kept reading big PCRs. They asked you basic PCR का sequence बता दो. So what happens over here? First, the double stranded DNA is converted into a single stranded DNA. This process is known as denaturation, which is done at 94 degrees centigrade. After you've separated the 2 strands, now you're going to add primers. You're going to stick something. So that sticking is known as annealing, which is done at 54 degrees. After you've done the sticking, now you will start extending. This process is referred to as extension, and that is done at 72 degrees centigrade. So they asked you, they didn't even ask you the the temperatures. They just gave you 3 names: denaturation, annealing, and extension, but you had to put it in the right order. Someone asked me the difference between blotting. Oh, acha, I didn't mention that because I thought अब वो इतना वो dosa, roti, pizza must be so common that आता ही होगा type of a thing. But if you want me to revise, then अब जब इतना बैठे हो तो me sit for another 30 seconds. Southern blotting, northern blotting, western blotting, तो you will tell me. Then you will tell me eastern blotting also. When I say south, south में क्या dosa is consumed ना, so dosa के लिए you will remember DNA testing. North में roti, तो roti is going to be for RNA testing. And west में pizza, तो pizza pizza के लिए you will do protein testing. And Eastern के लिए क्या बचा? Eastern is going to be for post-translational modification. It is going to be post-translational modifications. I think this roti dosa pizza is pretty common with examiner also. पूछेंगे तो शायद अब ये पूछेंगे. Where do you do Eastern blotting? It is done for the post-translational modification. Okay, now I'm left with two main topics that I want to tell you. One topic is going to be amyloidosis, and one topic is that anti-nuclear antibody ka immunofluorescence patterns which all of you mess up in. So I have to teach you both of these, which means by 3:15 or 3:20, if everything goes well, it is going to be done for all of us. So now let me start with the simple wala question which all of you are going to quickly answer. Pehle, can you help me with this so that I can start with the tables? Two questions I've got from amyloidosis, and after that there is a list. INI-CET students, please don't bombard me, ma'am flow kahan gaya, CD kahan gaya. Listen to the plan after it. Okay, what is it? तो अभी पहले जो पढ़ना है पहले वो पढ़ लो. We can't do everything else in 3 hours. It's impossible to finish general path and HEMAD and a lot of other live session questions in 3 hours. So there is a plan, but wait for me to finish. Match the following कर दो. Now coming to chronic inflammation. Chronic inflammation में क्या होता है? Chronic inflammation is going to be AA. ठीक है, ये तो एवरीवन इज सेइंग. ठीक है, एल्जाइमर्स डिजीज में क्या होता है? ए बीटा. ओके, वेरी गुड मैम. 1 ब्रेन 1 बीटा वाला निमोनिक वी रिमेंबर. फेमिलियल अमाइलॉइडोटिक पॉलीन्यूरोपैथी में इट इज गोइंग टू बी ATTR. ओके, एंड डायबिटीज मेलाइटिस में आइलेट एसोसिएटेड, कुछ आइलेट से रिलेटेड होगा. ठीक है, तो अमाइलॉइड का मैच द फॉलोइंग तो यू प्रीटी मच आर गुड विद. तो देन यू फिल इन द एंटायर टेबल. ना उल्टा शुरू करते हैं. मल्टीपल माइलोमा इज अ ट्यूमर ऑफ द प्लाज्मा सेल्स. प्लाज्मा सेल क्या बनाएगा? लाइट चेन. सो मैम इन मल्टीपल माइलोमा व्हाट इज गोइंग टू हैपन? लाइट चेन मतलब विच अमाइलॉइड? AL टाइप ऑफ अमाइलॉइड. जल्दी से फिनिश ऑफ. यू हैव, आई एम गिविंग यू अ टारगेट ऑफ 60 seconds. यू हैव टू फिनिश ऑफ दिस टेबल 1 minute में. Hemodialysis, ma'am 2 kidney. You used to say 2 वाला A beta 2. A beta 2 is what? Beta 2 microglobulin. Very good. Alzheimer's में 1 brain. Hopefully 1 is working. I don't know till the exam whether it will. So beta for what? It is going to be beta plaques. Alzheimer में beta plaques. Very good. Let's go on to these two. The toughest one. Old age. I learn it in simple words. Senile means old age वाला amyloidosis. And neuropathy मतलब nerves वाला amyloidosis. In both of them, it is going to be TTR. In both of them, it is going to be TTR. TTR stands for transthyretin. And ma'am, the difference is that in old age, as the age is increasing, it is the quantity of TTR which is going to increase. Very good, guys. And in nerves wala, it's the mutation of TTR that is going to happen. So age increases, quantity increases, mutation happens, the nerve gone. Now coming to medullary carcinoma, the tumor marker is calcitonin, which means that now the next one is amyloid A, cal for calcitonin. सबको आता है, very good. Now for all the other 3 that we have, the amyloid is common, that is AA. Chronic inflammations में AA, but exception of chronic inflammation which does not lead to any amyloidosis is what? Chronic bronchitis. All inflammations cause AA, but bronchitis does not. Cancers, कोई भी कैंसर, इनके 2 फेवरेट कैंसर्स आर रीनल सेल कार्सिनोमा एंड हॉजकिंस लिम्फोमा, विच आई एम टेलिंग यू कि इस पे क्वेश्चन आता है. दैट इज ऑल्सो AA. एंड एनी काइंड ऑफ फीवर, especially familial Mediterranean fever, in medicine they will ask you that familial Mediterranean fever is because of a pyrin gene mutation, उसमें भी AA. Now my next question. अभी तक you studied इंटरल्यूकिन 6 में मैम मल्टीपल माइलोमा के प्लाज्मा सेल्स होते थे. इंटरल्यूकिन 6 हमारा कोविड में भी बहुत प्रॉब्लम करता था. इंटरल्यूकिन 6 अनीमिया ऑफ क्रॉनिक डिजीज भी करता था. यू नो इंटरल्यूकिन 6 is also going to be the one that is causing AA type of amyloid. Where is this coming from? This is also due to interleukin 6. This interleukin 6 is a big headache, not just in COVID but otherwise also in life. Now coming on to all the match the followings, you have done very well. Inflammations all except chronic bronchitis AA. Alzheimer's एक brain एक beta. Very good. Nerves वाला में ATTR कौन सा लिखे? Quantity या mutation? Nerves वाला में मैम we will write mutation. And next for diabetes what is left is islets. Islets तो pancreas के will go with diabetes only. Matching is done. Amyloidosis is not. There's another question. Identify the false statement. You have to tell me the false statements. You have 5 written in front of you. Combination बना के मुझे बता दो. 1 2 3 2 3 4 1 3 5. Maybe multiple, maybe single. So it is a proteoglycan. It is a misfolded protein which is going to be depositing intracellularly. It is cross beta pleated sheet on light microscopy. 95% of them are fibril proteins. It appears as basophilic hyaline extracellular. I want to start off. Number one, it is a proteoglycan. ये तो ठीक था. It is a misfolded protein, I agree, but does amyloid deposit intracellularly? The definition of amyloid I want to ask you. It is an extracellular, first word, it is an extracellular pink color protein. And that too not a normal protein, it is a misfolded protein. इस पूरे word को याद करो. Where is it present? Outside the cells. How does it look like? Proteins are always pink in color, and what kind of a protein? Misfolded. तो intracellular, ये गलत हो गया. Next, does it show beta pleated sheet on light microscopy? Light microscopy पे तो कहाँ मैम वो pink, blue, basic दिखता है. कहाँ will you see beta pleated? Beta pleated is like something I'm saying that by with my eyes I'm able to see as an X-ray vision I'm able to see your bones. It's something like this, which is not possible. If I have to see your bones, I will have to see via an X-ray. So if I have to see inside, I will have to not use light microscopy. Beta pleated sheet is seen by X-ray crystallography. उसका भी अंदर देखना है तो you will have to do X-ray vision से देखना पड़ेगा. So this is also a wrong statement. 95% of them are made up of fibrils. ये ठीक है. Option 5 everyone said हाँ मैम आप ही ने तो बोला extracellular है. But then I said protein है ना. Protein has to be pink. They have written blue. So this is also wrong. Now tell me what are the wrong statements. 2, 3 and 5 are going to be wrong statements. Finally started getting the answers. I would have given you options, then you would have discussed something and done 1, 3, 5, 2, 3, 5. But in the exam, always make your own answer and then search for options. Otherwise, you will fall for the trap that the examiner has given to you. So coming and taking you back, that over here, when you're talking about amyloid, whenever amyloid goes and deposits, I'm telling you the diagnosis. Whenever amyloid goes and deposits in an organ, it becomes waxy. They write waxy kidney, waxy liver, waxy spleen, waxy heart. Waxy matlab amyloid. The stain I think I taught you yesterday also is the Congo red stain. Congo red stain gives you what color? It is going to give you apple green birefringence, which you've studied. You can see the apple green color. On which microscopy? On polarizing microscopy. Now, why is my question over here? Why apple green birefringence? That is due to the beta pleated sheet configuration. And beta pleated sheet configuration is seen on which microscopy? Ma'am, it is going to be seen on no microscopy. Beta plate मतलब आप अंदर देख रहे हो. With X-ray vision you will require. So that is known as crystallography. Okay, now X-ray crystallography पे you are seeing beta pleated sheet, Congo red का भी हो गया, but they ask you a question. Can you use another stain other than Congo red, which is known as thioflavin T stain? Yes, you can, and the light that you will require, ये कितना detailed question आता है. The light that you will require is going to be the ultraviolet light. These are questions for all exams, but now I want to tell you questions, last thing on amyloid, which are again for all exams. If you want to take, question I will add over here. If you want to take a sample, what is the sample site for amyloidosis you will take from? Earlier the answer used to be rectal biopsy, but then they found rectal biopsy कितना painful है patient के लिए. Plus what if you damage the anal sphincter? I mean that's dreadful. So then they said okay, go for something simple ना, go for abdominal fat aspiration. Patient भी खुश, मेरा abdominal fat निकल गया, kind of that ways, and it's less invasive for the patient. So the best is going to be abdominal fat aspiration. This is for all exams. The second question is only and only for INI-CET students. How do you know the extent of amyloidosis? How much percentage of the body is affected? Has it gone into all organs? Has it gone into 50% of the body? For that we have a technique which is known as scintigraphy. Scintigraphy is done to know the extent of amyloidosis. So this is also done. Now I come to the next point, which you will tell me, which is everyone's worst dreaded topic. Which of the following immunofluorescence pattern which you see on CREST syndrome? Ma'am, you've procrastinated and saved the worst for the last. Usually it's the best, but the worst has been saved for the last. So batao. A, B, C, D. Okay, D. Can you tell me the name of this D pattern that you have mentioned over here? What is the name of this D pattern? CREST syndrome में centromeric pattern comes. And now I'm going to teach you each one of these patterns. And what are these patterns? This is obvious that this is immunofluorescence. Fluorescent microscopy दिख रहा है ma'am, common sense. But over here, these are patterns of an antibody. Listen very carefully, सुनोगे, समझोगे, you will get questions right. It's just about patience of spending 2 minutes on this. Anti-nuclear antibody can be in SLE, it can be in Sjogren's, it can be in scleroderma, it can be in any autoimmune disorder. So that means these patterns can be seen with anti-nuclear antibody in any autoimmune disorder. Now asking you, the patterns are learnt by something called happens. You can see that happens 5 patterns, which I will come to one by one by zooming in. The first pattern, whatever I'm writing, reading and drawing, so that you know exactly क्या चल रहा है. Homogeneous pattern means everything in the nucleus. See, what is the name of the antibody? Anti-nuclear antibody. My focus is only on the nucleus. Forget the cytoplasm. Nucleus. The entire nucleus is green. That is homogeneous. Means the entire nucleus is gone. Antibodies have targeted the chromatin also. Antibodies have targeted the histone also. Antibodies have targeted the DNA also. Ma'am, everything gone. That is anti-nuclear antibody homogeneous pattern. Yaad rahega, homogeneous everything. Coming to the next one, and that is peripheral. When I say peripheral, you will notice कि अच्छा ठीक है, everything is green, but the periphery is slightly more green. If I had to draw it, this is how I would draw it. The nucleus is green, but can I notice that the periphery is turning out to be a little more green? And this is, I'm going to make a snake-like DNA on the side. वो ऐसे इसलिए आया because antibodies are against what? Antibodies are against the double-stranded DNA. Are we okay with this? Coming to the next, nucleolar. I'm not saying nucleus. Nucleus तो मतलब मैम पूरा green हो जाता. Nucleus के अंदर, inside the nucleus, I'll draw the nucleus with another color. There is a green color dot, nucleolar. Nucleolar pattern is going to be against RNA. And if I zoom into this, you will notice that nucleolar is just, ma'am, the nucleus is not highlighted. Nucleus gayab. Only inside it I can notice one dot. That is known as the nucleolar pattern. Now moving on to what all have you done? Giving you a recap. पूरा homogeneous कर लिया, फिर peripheral वाला कर लिया, फिर nucleolar कर लिया. Now you're left with 2. The first one is going to be speckled. So speckled is these 2 photos. First I want to put side by side because सबको इसमें maximum confusion है कि मैम speckled and centromeric same लगता है. So now the difference is that I will tell you. In speckled also I agree, थोड़े से बड़े वाले dots होते हैं. Speckled is थोड़ा सा बड़ा dots. So if I zoom in now, you will see that yeah, the nucleus is not fully green. I can notice the nucleus has black holes and then green big dots, then black holes and green big dots. So yeah, there is some green black jaisa appearance. That is speckled. Please note that the speckled pattern is the most common pattern. It is going to be seen in any autoimmune disorder. Let me ask you, because there are antibodies against anti-Smith, which all of you were mentioning. Anti-Smith किसमें मिलता है? SLE. So this pattern can be seen in SLE. They are seen in anti-Rho and anti-La. Anti-Rho and anti-La are seen in Sjogren's syndrome. So this pattern is seen in Sjogren's syndrome also. Can I say because it is the most common pattern, this is also the most non-specific pattern that we have? Is that okay? Because sab mein dikhega to it is non-specific. Then ma'am, when do I make centromeric? See, if I would show you this photo, you will say, isme bhi to green color dot hai. But can you see how sharp those dots are? If I compare with the previous photo, over here, those green color dots were a little, thoda green tha, but they were not shining or piercing my eyes. In this, the green color dots are very sharp. They are very distinct. That is centromeric because every chromosome has a centromere. So that sharp green color dot is centromeric, but nahi identify hoga ma'am exam mein. So then the trick is you are seeing pura chromosome. In centromeric pattern, you can see a proper chromosome being arranged over here. That is centromeric pattern. And centromeric pattern is obviously which antibody? Anti-centromeric antibody seen in which syndrome? It is seen in CREST syndrome. So now I want to ask you once again, let's take a test. Ye wala kaun sa pattern? Just a test from this slide. Which pattern is this? Ma'am, everything is green. So this must be the homogeneous pattern. The next one, only periphery. That is the peripheral pattern. The next one, only green color dots are there. That is the nucleolar pattern. The next one, pura chromosome dikh raha hai. That is going to be centromeric. So in CREST syndrome, centromeric pattern will be seen. Before I end the class, you will guys tell me what is CREST syndrome. Jaldi say the findings. One is going to be calcinosis. I've started writing. You also start typing ASAP. What is R? R is color changes in the fingers. That is Raynaud phenomena. E for esophageal dysmotility. The person will say that I can't eat food. There is difficulty in eating, dysphagia. Okay. S for sclerodectine. sclerodactyly. Sclerodactyly means that sclero is sclerosis, dactyly is digits. In the fingers there will be sclerosis. You will want the patient to open his fingers, but he will keep his fingers like this, like a claw, this kind of a claw bent hand, because he has sclerosis, sclerodactyly. And T for what? T for telangiectasia, which you know, dilation of the ectasia, dilation of the blood vessels. So CREST syndrome is going to show you anti-centromeric antibodies, and that is what is seen over here, which is done. Itna अच्छे से पढ़ा. So now what I'm going to help you with are two things. First, I have kept a few bonus slides because I thought it would be very baby if I start discussing things like coagulative necrosis, liquefactive necrosis, क्योंकि वो first chapter होता है ना, first chapter में मैम next level confidence हम पढ़ ही लेते हैं. So bonus slides में all the necrosis are there. Then I have made a table of all the special stains that you will. Yesterday, did you get the bonus slides in the PDF? It's already there on the Telegram group, my Telegram group, PrepLadder Telegram group, before that influx of messages start. So this time I have kept photos of all necrosis. This time I have kept photos of all the stains for your end day revision. I have kept photos of all giant cells in your bonus slide. I have kept photos of all granulomas that you have to know. So ये सब photo fest I have done for you. After that, for your last day revision, I have made a table of all the tumor markers that you have to go revise and go. And for your last day revision, I have made a list of all the autoimmune disorders and antibodies. ये अभी याद नहीं भी करो, never mind. But on your last day, you scan through these bonus slides before stepping into the exam, because this is something that will help you. Now coming to what INI-CET students are going to have. They will have a list of techniques. So I will cover the techniques in a separate session before INI-CET, but this is already there in rapid revision. So now when you are revising subjects 1 day, 2 day per subject, and whenever you do your patho revision, these are the topics which are apart from this LRR only for INI-CET students may exam that you have to focus on apart from these LRR topics. So this I have done in the PDF. PDF में आपके separate, and I will come to these when I have to teach you. You know, Telegram quizzes and sessions keep happening. So this is a separate. I can't fuse these topics with everyone else's topics, because then the LRR would go very off track, and then it would be one session for 10 hours, which wouldn't make sense for anyone. So this is a separate thing. And the bonus slides में ना और भी छोटा things I've done, like आउलाई इतना बात करते रहते हैं, तो I have mentioned आउलाई. Then I didn't mention stupid things like crumpled tissue paper appearance is seen in Gaucher's disease. मतलब the things that I know कि इन्हें आता है, मैंने पढ़ा ही दिया. Gaucher's में crumpled tissue paper appearance, आउलाई seen in Reed Sternberg and CMV. All these 7-8 things I have put in the bonus slides. Tumor markers are there, antibodies are there, stains are there. So जो वैसे भी छूटने वाला था RR में, all of that is there in bonus slides, because I know छोटे version में you will be able to read, otherwise it becomes difficult. Okay, finally. Same duration as yesterday, and our LRR is done. 1 day break I have taken, you have not, because you have medicine LRR tomorrow, but I will meet you on Monday and Tuesday. Timing of both sessions will be 12 noon, and we have two very extensive microbio, everyone's favorite subject, coming up. So we have two microbio sessions just for your for your own orientation. The first day we will do general micro, we will do fungus, and we will try our best to pull a lot of parasitology also. The next day we will do half of parasitology, bacteriology and virology. That is how it goes. ठीक है. Now स्कार फॉर्मेशन 21 days ही होता है, बाकी सोर्सेज को भूल जाओ. डॉक्टर श्रीम, एज यू हैव मेंशन्ड, अदर सोर्सेज जो लिखा है, what is there in rapid revision, as you have read in my, I have taken it from Robbins, it's the source, consulted well. Then first biomarker in myocardial infarction, IMA and HFABP, there will never be an option between these two, because both of them come early, so be rest assured. Most common cancer due to asbestosis is, I've told you, most common cancer adenocarcinoma, most specific mesothelioma. जैसा पढ़ा है वैसा exactly है. Okay, why do we see thrombosis in PNH, Dr. Ahmed? That is because of thrombosis always happens whenever there is any blood vessel injury, endothelial injury. So in PNH, because the blood cells are breaking too much, there is endothelial injury that can trigger thrombosis. MRAT-COP में क्या पढ़ना है? MRAT-COP, if you mentioned, then you know MRAT-COP. ऐसा बहुत ही simple things I have not gone into, because things that I know you guys will focus on, so I have not included those. I tried to include something which otherwise you will not study. Osteoid, osteoma and osteoblastoma, Dr. Amit, I think you were asking yesterday also, patho में तो कोई difference नहीं है. These are differences that you see only and only when it comes to the clinical aspect. Bone tumors, size का difference है, site का difference है. Radio and patho, both of them is the same. This is not a radiopathological diagnosis. This is a diagnosis which is made clinically. Immunology में Dr. Nishta, we have done the the inflammation वाले immunity disorders we have done. Then amyloidosis is a very important topic. Grafts I have not done because in surgery you do all those allograft, isograft, वो तो वहाँ पढ़ते ही हो. Anything else you want me to cover, you can let me know. Coming to all your questions one by one, PDF will be put up on my group and prep group, but after 10 minutes after I finish this session. उससे पहले it's not possible. Okay. Toxicities of drugs there's always a variation. It can be done, like for example, if you're asking about lead poisoning. So lead poisoning ideally is done in a tan vacutainer, which is containing EDTA, but it can also be done depending on certain which are found in the serum, then it would be done in a red vacutainer. So there is always a variation between which drug toxicity you're wanting to look out for. Part 1 of this video, Dr. Dipanshu, is already there on the app. On PrepLadder कल वाला ही session है. Okay. Q banding is preferred for Y chromosome. Yes, because Y chromosome is little difficult to spot otherwise. So Q banding is what is preferred, but in most of the cases, and a person who's advanced and who is well read or well exposed to the genetic reports can view it on a G banding also. LRR, PYQ enough, Dr. Philip. To be very honest, LRR will never be enough to pass any exam. I don't want to give you false hopes here. I don't want to say LRR karke chale jao, you will pass, because then our students, other students, just for time pass reading rapid revision and main videos. Let's be honest, FMG exam has become very tough and LRR alone will not suffice. LRR will be a very good source for revision, but not your only mainstay of studies. I am sorry to say this, but nahi ho paega. 3 revisions of patho for FMG. What next to follow? Nothing, Dr. Devaki, you are good. Just do 3 revisions done. Matlab now rapid revision, Q bank, rapid revision, Q bank on loop. That's all that you cycle between. FMG student 4th year LRR, not at all. Go for main videos. After that, closer to exam, go for rapid revision. LRR last 2 months, not right now. Part 1 of LRR, Dr. Dipanshu, I've told you, done yesterday. Prep Q bank okay for FMG exam practice. NEET PG Q bank, हाँ it's okay. See NEET PG FMG ना 5-10% का difference बचा यार, अब to be honest. INI-CET का तो फिर भी 10-20% का difference है, but the exam pattern is different. FMG doesn't have negative marking, NEET PG has. That makes NEET PG tougher because of negative marking. But when you talk about topics and the questions being asked, then that ways the level is becoming pretty similar. So even if you've taken a NEET PG Q bank, it shouldn't bother you. No, Dr. Raghav, there is no other offline class planned. Okay, quizzes after the thing is done, after the, the LRRs are over. Okay, MHC I will try. Yeah, so Dr. Emma, platelet aggregometry I have mentioned over here. Na, ये तो INI-CET के specific वाले topics हैं. So this is mentioned separately. Okay, 4th year wala question I have done, sir. I think some of you have copy pasted the same again and I have taken time, but I think we are done. Diagnosis of Wilson, it depends. We are obviously not just going to do copper levels, we are going to do ceruloplasmin levels also, and genetic testing should be done because in Wilson's, it is the ATP7B gene mutation that is seen on chromosome 13. So yes, genetics. Okay. Yeah. Okay, so guys, for general path and hemat, I think this is the best that I could squeeze into 3.5 hours or whatever, but beyond this, it is not possible to add on more because then it becomes just another rapid revision. So the concept is to include high yielding points for you, which I anyway have. Bonus slides are also added, but iske baad, if I add on another 2 hours, then I'm actually closing on to a rapid revision, which wouldn't make any sense at all. Still, I am making a list of all the topics. Be rest assured, I have never let you go without revising a topic anywhere. Ask your seniors if I have ever let them go without revising a topic. So somewhere or the other, I will make you revise it, be it on Telegram, be it on quizzes, be it near the exam, maybe YouTube session. We will do it, but let LRR remain the essence of LRR remain intact. Otherwise, we will dilute it so badly that it will become another rapid revision, and that's not going to help anyone. Yes? Okay. Sure. Done, guys. So, everyone, टॉपिक्स जो होंगे वो मुझे टेलीग्राम पे बता देना. आई विल मेक अ लिस्ट. आई विल लेट यू नो हाउ वी आर गोइंग टू प्रोसीड विद इट. LRR related, this is it PDF you will find. And I hope these sessions, whatever we have studied, I hope this has been useful for you. पहले इतना पढ़ो. Finish this. Prioritizing for every exam is important. पहले ये दो PDFs और ये दो LRRs you have to finish. Then try giving one champions exam, especially the INI-CET students. Then we will think of the phase 2 of LRR, or we will think of phase 2 of what other topics we can do on quizzes, other sessions. But पहले bare minimum, we start from priority. Most important 50% of syllabus you finish. Then we'll come down to the second part of it. But we can't put everything in one and then you'll be like, ma'am, RR पढ़े या LRR पढ़े, because वो भी 10 hours, ये भी 10 hours. Then what sense did we make out of it? Nothing. Okay, so then first you finish this much, give the exam, then we go into phase 2 of studies. Okay, it has to go in an order. It can't go everything in one go. Okay, I will wrap up now. Don't want the session to be lengthier than this. Thank you so much for all the patience, for giving up on your lunch, unless you were eating alongside. But do make sure within 1 to 2 days you revise this session. One quick scan through of either the video on 2x or the PDF alone. But a quick glance through the topics once again will add it into your memory, right? Thank you. Thank you so much for joining in, guys. Take care.